Morning, everybody. We'll call to order the meeting of the Public Employee Benefits Program for today, July 23rd, 2026 at 9 a.m. Can I get a roll call, please?
Thank you. Chair Jim Wells.
Here.
Kate Duncan. Here. Laura Rich. Here. Ken Barnes.
Here.
Lynn Harper. Here. Town.
Here.
Joy Grimmer.
Here.
And Dr. Paul Davis.
Here.
That concludes the roll call. We do have a quorum. Please remember to state and spell your name for the record. Thank you.
Thank you. We'll move to public comment. Agenda item number 2. Public comment will be taken during this agenda item. No action may be taken on any item raised under any matter raised under this item unless the matter is included on a future agenda as an item on which action may be taken. Public comments to the board will be taken under advisement will not be answered during the meeting. Is there any public comment? Good morning.
Kent Urban, Kent-Erbin, my words for the record. Good morning. I'm looking forward to a productive discussion today. In addition to today's agenda, the PEB board needs to have strategic discussions on the underlying issues raised by PEB's fiscal crisis and the April 16th memo from PEB about health authority leadership. Beyond the specific findings and correction actions, how did PEB's financial crisis arise without the PEB board knowing about it sooner? What structural changes are needed from PEB board governance? I have not been able to review all 118 pages of the presentations in detail since it was only posted 16 hours ago. However, one area of concern is the discussion of risk pools beginning on page 27 and purple over there. Regarding separately rating actives and retirees, NRS 287 mandates that actives and retirees be commingled in a single risk pool, so separate risk pools are not an option. There are good policy reasons for the statute. Foremost, it prohibits direct or indirect age discrimination in employee and retiree premiums. Also, number 2, the idea of moving non-Medicare retirees to the exchange is questionable. Medicare eligible PEB retirees are already required to be on the exchange. There are 2 main groups of non-Medicare retirees, those who are younger than 65, not yet eligible, and those who were hired before public employees have had participated in Medicare, which I believe was the 1980s. These retirees are mostly in their 80s or older and will never be eligible for Medicare. I don't know how many are left. There is both a legal and a moral obligation to continue them on the PEB health plan. Both of these things being in the packet suggest that institutional knowledge about the plan either has been lost or not transmitted to the consultants. A comprehensive review of the PEB duties, policies, and procedures manual is needed to ensure that board policies regarding plan design and rate setting are fully defined and transparent, as well as very defined what the board delegates to staff or consultants and what actions must be reported to the board. Rate setting policies need to be defined in writing, and then any exceptions explicitly approved by the board. For example, the formula for rating the 4 dependent tiers within a plan option is not included in the policies and procedure manual, and also has not been presented to the board at rate setting time for the past few cycles. As I recall, the formula was established when Chair Wells was executive officer. The formula appears to still be operational, but has not always been adhered to exactly. A written submission includes other suggestions on each of the 5 topics. Thank you for your service and consideration.
Dr. Urban. Any other public comment here? Seeing none, we'll close agenda item number 2, public comment. Move to agenda item number 3, PEB board disclosures. Deputy Attorney General Rivera.
Thank you, Chair Wells. Hello, everyone. My name is Jose Rivera, Deputy Attorney General for the record. This agenda item is to allow me to make a disclosure regarding conflicts of interest on behalf.
Maybe we can hike up the volume.
Can you say that again, Mr. Rivera?
Yes. Are you able to hear me?
I'm adjusting it higher, but it doesn't seem to be going up that much more.
Can you hear me now?
There we go.
Better.
Okay. Thank you, Chair Wells. Hello, everyone. My name is Jose Rivera, Deputy Attorney General for the record. This agenda item is to allow me to make a disclosure regarding conflicts of interest on behalf of the board members who are eligible for Public Employee Benefits Program, PEB benefits, pursuant to NRS 281A.420 on behalf of the board members who are eligible for PEB benefits or whose families are eligible for PEB benefits. I offer this disclosure that will be voting on those items that may affect the benefits available to them or their family members. The law does not require abstention from voting merely because the board member or their family member is eligible for PEB benefits. At this time, I invite any board member who has any additional disclosure to make it now. Thank you.
Thank you, Mr. Rivera. Any additional board disclosures for members of the board? Seeing none, we will close agenda item number 3, move to agenda item number 4, approval of the action minutes for the May 21st, 2026 PEB board meeting. Any comments, questions, concerns? If not, can I get a motion for approval?
Jim Barnes, move approval.
I have a motion. Can I get a second? Mr. Davis? Mr. Davis, was that you?
Yes, that was.
I have a motion and a second. All those in favor say aye.
Aye.
Any opposed, nay? Motion carries. We'll close agenda item number 4. Move to the meat of today's agenda item. I am now going to turn over the floor to Mr. Andrew Sherman. He is going to be our moderator for the rest of today's session. And so I will let him take it away. Mr. Sherman.
Thank you. Do you want to start or you want me to start?
Go ahead.
Sure. Hey, everybody. I'm Andrew Sherman. I'm with Siegel. My colleagues are here as well. Debbie Donaldson and Amy McClendon. Debbie and Amy and a lot of other people are part of the regular team that works for PEB and really are responsible for delivering services to you on behalf of the participants. My role at Siegel, my job at Siegel is I direct and have a authority over our public sector business from across the country. And it's really very special. I get invited to do things like this from time to time, and it's actually the part of my job I enjoy the most, to get actually involved with issues of the day and making sure that we can bring our best consulting to you. We also have colleagues at Milliman who have prepared part of today's presentation and are going to be part of what's going on. So I have an agenda, but just because you don't know me, I'll give you the 2-minute version. In May, I celebrated my 40th anniversary with Siegel. I'm one of those lucky people who was found an employer would have me for that long. I hope that I've added some value. I did have a job before Siegel. I was an intern at an HMO when I was in graduate school, and I did get a master's degree in healthcare policy at the Kennedy School at Harvard. So somehow that got me into employee benefits consulting, and I had a wonderful career, both delivering consulting advice, being part of Siegel's management. I'm on Siegel's board of directors as well, and now I get to usually go to meetings where there's concerns. Today I'm in a meeting where we actually are going to do some problem solving, and I thank you for the opportunity. So here's what we're proposing. So maybe go back. Sure, that's okay. But you probably read this while I'm talking. So we have some discussion topics, and you'll see these as we go through. We have a proposed structure for how to spend your day. You all are the board, so the meeting should really be as you want it, and I'll do my best to facilitate in a way that I hope will be helpful to you. But if it's not, let me know. On this next slide, just want to make sure that I think it was board member Joy who's making sure she can hear me.
Yes, I can hear you.
Perfect. Okay. So what we'd like to do today with you is a facilitated discussion, providing a forum for board members to examine priorities, goals, and strategies for PEB to consider. And we've divided this in a way that we hope makes sense in 5 big categories: plan design, risk pools, contracting, pharmacy, and disease management care coordination. We're suggesting that there not be more than an hour for each topic. And we're going to ask you to express some preferences even before we get started. On the next slide, we have a guiding principle from your materials. So I'm hoping you've all seen this before. And I want to pause here because this is where I give it to you, Teresa, for the letter.
Oh, yeah. So, as we have heard from public comment, there was a reference to a memo that Director Weeks sent out on April 16th. That's located on our website. I think it might have been shared with you all beforehand, but we just kind of wanted to level set and remind people there were 5 findings as part of that memo. And the first finding was that PEB's revenue tracking methodologies lacked safeguards to ensure that the state collections were accurately reflecting the employee and retiree collections. The second finding was that the PEB internal accounting procedures for reconciling those owed payments with state employers, that those were found to be inaccurate procedures. The third finding was a surplus of funds used to buy down member contributions after COVID to mitigate premium increases were not accurately tracked in our benefit delivery system, referred to as Ariel, and nor were they discontinued after that funding was depleted. So that continued the offset to the premiums. Finding 4 was that the budget workbook that was submitted to GFO, the Governor's Finance Office, and the Legislative Council Bureau teams during budget build for that last biennium was outdated and incorrect. And the amount of money that was budgeted for was a total amount more than could be collected based off of PEB enrollment, expected enrollment, and then actualized enrollment. So you hear a lot in public comment, people talking about the budget missing money. It's not missing, it's money that was given an authority, right? But we could not collect it because we did not have the number of members paying premium that was expected. And then the 5th and final finding were that the rates and coverage decisions by previous boards over the last 4 years drove migration to plans that were not covering the cost of their members and increased benefit coverage with no increase to premium revenue to cover that increase in benefit coverage. So those were the findings. I think over the last several board meetings, we've talked about the different things that were put into place to correct those findings. If you guys want to take time to go over that letter or ask additional questions, we're happy to do that. But I know you guys also have a lot of work to do on your discussions of other topics. So happy to move toward whichever item you're willing to discuss right now. Anybody have questions about the memo? Has everybody seen the memo? Okay.
I, Paul Davis. How can we sure be confident that these issues have been corrected?
Yeah, I think, the health authority hired a contract physician to come in and do an audit, and that's how we found all of these and implemented systems and practices to correct them. We've met with members from the Governor's Finance Office and the Legislative Council Bureau, and they seem happy with the improvements that have been put in place, and we're working with them more closely this year for budget biennium build 28-29. And so far, those entities seem secure with the changes that were put in place. Did you have suggestions or ideas?
Well, part 2 of my question was, what were the consequences to this malfeasance? What happened to the people who made these errors?
Yeah, so the errors that were found were from previous administrations as well as board members. And so they're no longer here. I don't know that there's a way to hold them accountable when they're no longer here. Yep. Yes.
Just wanting to understand how the error, I think I understand what the memo is saying in terms of the error and how it affected the budget and the difference between legislative authority and the budget and the ability to draw the funds. I think the question I have is there not any way through, I assume we can't through IFC, but is there a way in a supplemental request at the start of the session to request a change in the authority to allow us to draw the funds that were budgeted? Because it seems like the intent was to provide the assessment, the support to restore the reserves. That was the intent of the budget. That's what the
Yes,
numbers were based on. But the error is leading to us not actually being able to draw it. And that's part of the reason we
Yeah,
have a
so
short.
part of it was the error in drawing and the other part of it was the error in the previous board and how it was expended, right? So what was drawn down was not expended and saved the way that it was initially given. So, at the start of this next biennium, the ask for the budget will be to cover the costs of the current budget. But I think, you know, that I'll have to go to the table and answer some serious questions about why that money under a different administration was expended differently when it was given to reestablish, you know, the reserve program. And the reason that didn't happen is because the money that was collected was used to offset premium costs. So again, those were board decisions. When you guys vote on rates, that impacts that. So, not saying that it was anybody on this board, but those decisions resulted in those revenue streams not being used the way that they were budgeted.
One last question. Paul Davis, one last question. Are you prepared in case legislature does not offer that money? Do we have an emergency fallback?
So we have 3 reserve accounts, and those reserve accounts are what has been underfunded. That's what board member Baton was talking about, right? So like a portion of the money that we were supposed to receive was supposed to balance those reserve buckets and build them back up and restore them. That didn't happen because the costs of the pharmaceutical and the medical claims ate that up, right? So, can you rephrase your question?
I guess I'm saying, do we have a plan B if the legislature is not positive towards us?
Well,
Right.
so one of the things that we discussed with Siegel is what the definition of solvency is, because I think we're going to be asked that. I think historically by PEP policy, that shows that there has to be certain funding in each of those 3 reserve accounts. And in speaking with Siegel from an actuarial perspective, they said that as long as we had the funding to maintain the IBNR account, that they would, from an actuarial perspective, sign off that the program is still solvent. So the question will become is, as we start this year and as we move through this year, do we have enough to cover the amount that is required for program year 27? And that amount will come in a letter from Siegel in the middle of August, I believe. So I don't have that number yet. But just based off of last year's, we can assume that it'll be similar to last year's with an increase for trend and adjustment. We are balancing forward in 27 about $56 million. So it's entirely possible that that amount would cover what the letter shows, but our balance forward is also the cash on hand that we use to pay bills. So you have to understand that while we're collecting revenue, we're expending for our medical and our pharmaceutical claims. So as we're doing that out of a $56 million bucket, it's not entirely possible all that money is going to be there.
Okay, thank you.
Laura Rich, for the record, I think to answer your question, if the legislature doesn't come in and save the day, I mean, with maybe some, small little exceptions. The bulk of it is either you raise premiums or you lower benefits.
Yeah.
You reduce benefits. So
And I think
that's really what it comes
today's
down to.
discussion is to like, what can be done possibly short-term or long-term. I think a lot of these options are more longer-term options and aren't gonna hit this year, but yes, I agree. Because our revenue comes, from state employer contributions and member revenue, that puts us in the same pickle we were in last year, right? Where we had to raise the premiums.
I get the sense that people are still thinking in terms of spend down, but the Q3 budget report from 2026, and I don't know, I guess like last July, there was a Q4 at the July meeting. Hopefully next meeting, that
Yes,
information
this
will
is
be
your
available
strat plan
for
meeting,
plan year
so you-
26.
yeah.
But I took away from the Q3 report at the last meeting that actually some recovery, things are moving in the right direction. If there's sort of a, deadline for, budget prep, that there's some declaration of solvency, I think that what just happened with the premiums is going to potentiate that movement in the right direction for the reserves. The impact to participants can't be ignored. I just want to make sure that that's still fresh in people's minds, so that the decision-making today does not continue to impact participants in the way that just happened for Plan
Yeah.
27.
I agree with you, Member Harper. I would add, even though rates were increased and they are all difficult for everybody, and I think nobody here would argue that point at all. They are not reflective of the costs that we were expecting to see this year. So they were implemented with a $30 million decrease to our revenue. So even though we see movement forward, we're trying to figure out where to come up with $30 million. And so as we move through the year, that will show, especially where the migration occurred through the enrollment changes, how hard we are impacted by those rates and the incomplete ability to collect the entirety of the revenue.
Absolutely.
Yeah.
How soon will the board be able to get a look at the changes that we're seeing from open enrollment?
I believe we can present those at the August board meeting.
Absolutely last question. Do we have effective?
You don't have a number. You can ask as many as you want.
Do we have effective lobbyists representing this board?
Representing the board.
Well, yeah, the board and also.
I mean, I think and Chair Wells, you can clarify. I think that I am the one that the executive officer position has been delegated to act on behalf of the board. The chair of the board can also speak to lawmakers. I think historically that's not happened. I know that the Director Weeks and I are trying to get meetings with lawmakers to talk about the impacts to PEP, but as far as having a hired lobbyist, I'm not aware that you guys have had one of those or do have one of
Will
those.
be presenting to the state legislature.
Myself and Director Weeks.
Yes, okay. Okay. Well, I guess if it is effective, then. Thank you.
Uh-huh.
So before we go on to kind of follow up on what Direct Member Baton was asking, the only way for us to increase our authority is for a bill in the legislature to increase the state share. If they do that, that will impact every single budget that is in the state. And so they would have to come up with the resources and make other cuts to increase the 990 or 943, I guess it is this year. So there's no real way for us to just get money.
What's rather dire.
That's the way the system is built so that everybody pays in their share, be it the employer or the employees or the retirees. So to get a supplemental appropriation, or we're not eligible to go to IFC contingency funds, but to get a supplemental appropriation basically means that the general fund only is participating, as opposed to the way it currently is structured, where all state sources of revenue participate. And so you do that, and that general fund, that additional general fund then comes out of other general fund priorities. So the program has done it twice in the early 2000s. I prefer not to do it again. That's why the catastrophic reserve was added, was to prohibit that from having to do it again. So if we were to do that again, there would probably be, the legislature would probably require fundamental changes in the way that the plan is operated.
Thank you, Jim.
Any other questions for me? All right. Thank you.
So on the next slide, this is what I'm proposing to all of you as a way to construct a strategy session today. And again, your meeting, of course, but that we would spend time today, if you will, in the weeds with some ideas. And here are these suggestions that we offer, that all voices matter. The voice of each and every board member is going to matter today, and we want to have an opportunity for each of you as members to share thoughts and ideas based on this long list of suggestions that you see around the room and that we will go through. And to start with a very clear expectation that not everyone will be excited about every idea. You may be very unexcited about certain of these ideas, but there are a lot of ideas and limited time. So the real objective of today is to list reduce, if you will, from a large number of possibilities to a manageable number, and these are my words, for focus, detailed study, and then decision making. So again, today is to talk about ideas, to come up with ones that you want to focus on or we want to help you focus on, and lead to more study and then to decision making. And here's how we propose to do this, making sure everyone's speaking. So does everyone have their yellow dots? And you'll have other dots in the afternoon. So again, roles. Even though I'm with Siegel, my role is going to be to make sure we're having as good and robust and discussion and as much participation as possible. My colleagues and our colleagues from Millman are going to present information in 5 headings. And we've talked about not more than 60 minutes on each one. In fact, what we're going to aim for is no more than 30 minutes of detailed presentation, and then at least 15 minutes, I'll say, but probably no more than another 30 to hear for you all to be able to express opinions. If you have questions as we go, we're going to ask that if it's a clarifying question, something you don't understand, please interrupt so we can explain it, but that we kind of make sure we give enough time to hear the presentations and then have discussion. All that makes sense. Seems like a way you want to go. Okay. And just because having some guidelines on time is helpful, we've put that up. I think we're already a little bit ahead. So, but we didn't want to cut anything short to begin with. We're going to aim for, like I said, 30 and 15 for each. The breaks are certainly fungible. We can move them around. We have these 5 topics, and with that, I'm going to actually sit down and turn it over to start the presentations, if that's okay. Way to proceed makes sense? Yep. Thanks for listening.
Thanks, Andy. Again, Debbie Donaldson. I'm a senior vice president and actuary with Siegel. So what we're going to do and start off now is we're going to talk about the main topics And then I think we're gonna have you get up and move and put your dots where they need to be. So let's go over on a high level. And after you put your dots up, we're gonna dive into each of these topics in much more detail. So
Was I supposed to talk about the dots, or are you gonna talk about the dots?
we're gonna talk about the dots afterwards. I'm gonna hit the
We want to
subject.
tell you what the idea of the dots
Yeah.
is. Okay.
So again, we have major topics, and then under these major topics are subtopics that we want to talk about. So plan design, on this page is plan design, risk pool, disease management, care coordination. Under plan design, some of the subtopics we want you to consider, or we'd like you to consider, is full replacement with maybe single or multiple plan design options. So we'll talk a little bit about that. Maybe consolidating some of the existing plan options. Back in the day when Jim and I worked a long time ago, there was one consumer-driven health plan when Jim was the director. Talk about deductibles, what that looked like, maybe return the deductibles to maybe some of the levels prior to when those deductibles were bought down. That's particularly in the low deductible PPO plan. We'll show you some of that information. Expand HMO access. If some of you guys don't know, Kaiser's kind of in town here now. So we want to talk about that. Does that make sense? What does that look like? Happy to give perspectives. I'm from Colorado. Kaiser's in Colorado. I also have clients in California. Obviously, Kaiser's in California. So I'm happy to provide perspective if you would like. And then anything else you'd like to talk about with regards to plan design. On risk pool, we'll talk about, does it make sense to separate the actives and the retirees and maybe underwrite them separately and what that looks like? And then maybe we'll give you some costs, some estimated cost of, is there supplemental funding needed to mitigate the rate increase from non-Medicare retirees? Again, we're talking about budget concerns as well and funding, so we'll talk a little bit about that. Moving non-Medicare retirees to the exchange and dependent subsidies. We're going to give you some information. We've done some benchmarking of what other public entities are doing within the state. Millen is going to be presenting some of that information of what the subsidization looks like from employees versus the dependent. Again, anything else you'd like to discuss? Disease management. As we presented in the May board meeting, we talked about there's been a change in the industry looking at the whole health of a person. We're going to explore some care navigation. Again, kind of refresh your mind about some information about some of the condition management programs you have today and the effectiveness. Talk about GLP-1 coverage. As we know, these are really expensive benefits. Is there a different path to get to those GLP-1s because they're very expensive? Talk about any other kind of point solutions. For those who don't know, point solutions are additional kind of benefit offerings. They're kind of the hot thing in the healthcare industry, if you will. There's some good and bad associated point solutions, but some point solutions are very effective that we have found. So we'll talk about some of that. And then contract terms for utilization, care, and disease management. And then through procurement, right? Some of this may have to go through procurement process. So those are the subtopics under disease management, care coordination. Let's go to the next slide. We've got two other topics we're going to talk about today. Contracting procedures. Lots of items here, right? We're going to talk about direct contracting, procurement of the medical claims administrator, reference-based pricing. If you guys don't know what that is, we're going to talk a little bit more about that. Really tying in a high level, tying costs to % of Medicare. Is there direct contracting we should look at with some of the providers? Near-site clinics. Does providing clinics provide benefit? Some additional programs, how are you going to coordinate with the Nevada Health Authority and Medicaid? So these are some of the things we'll talk about, audits and other things. And then on the pharmacy side, again, that GLP-1 management solution, there's some new things that have been coming out in the industry to help with specialty drug management solutions. So we'll talk about some of those, and direct rebate contracting, and narrow network formulary, narrow retail networks, some point solution management, again, in the pharmacy space, which is kind of the newer things that are happening within our healthcare industry. And then maybe looking at the pharmacy benefit offering, are there plan design changes we need to make to the pharmacy benefit offering? So I think with that, let's talk about how we're gonna do this, because we're gonna have you get up and use your dots, right?
So you each have 8 dots. And those are for you to be able to express an initial preference. We'll have another opportunity in the afternoon following the presentation of the material and the board conversations for you to put up other dots. So there's a column that says morning dots and a column that says afternoon dots. And have any of you done the dots before? So what ends up happening is we have an instant picture of preferences. You each can place 8 dots. You probably don't want to put 2 dots on the same one unless you think it's like super duper important. And you can place the dots on any of these topics. You can place a dot on other if you wanted to do that, but we've got way more than 8. We want to see what you're kind of thinking. So we went through that really quickly. We should,
The first page of the different ideas.
Yes.
Question, so you want us to utilize all the dots?
yes, you can express 8 preferences
Okay.
wherever you like.
Okay, that's good.
Okay, and we know it's a lot of material at once. We've set aside time to do this. You can get up and walk around and read what's on there. And then that'll kick off the conversation. Remember, is it Grimmer?
Yes,
Maybe
yes, I will,
place her dots?
yes, I can place your dots, Joy.
Okay, I'll put them in the chat.
So
There we go.
Sure, Member Harper.
on the agenda, it looks like plan design and composition of brick schools are the AM slot. But do these AM, like, I don't know, how do they?
Oh, maybe I
I
wasn't as
have
clear.
PM dots.
Right, so are we? only
It's,
putting dots
we
like
have
that
AM
on
and
the
PM, but
schedule?
maybe the columns should be before and after the conversation.
Right. Yep.
So
Okay.
based on just
Just the
what we
first
said
column.
very quickly, what's your gut feel for where we should go?
Okay.
And then you're going to get a chance in the afternoon to put up other dots, because we think it's going to be interesting to see what your initial thoughts, how your initial thoughts may have pivoted or changed in the afternoon.
We're gonna go through all 5 topics. Some of them are bleeding into the afternoon, but after we go through all 5 topics, then we're gonna ask you to score again, not score, we're gonna ask you to put your dots.
Place dots.
Yeah, place your dots.
What else did I?
So
Say this the way you want it.
idea is that you put your dots on any one of the 5 now on where you think you would want the board to look for the various items and how they will impact the plans going forward. So what is your preference? I mean, knowing we've got to do something, what is your preference? You know, we've talked about this is the cost containment discussion, really. You know, what cost containment ideas do you think are most appropriate? And this is just your gut, like you said, your gut feeling for the morning, and then after the presentation, you have an opportunity to change your mind or not change your mind. You can keep them where you have them. You can move them. If you have others and have specific ideas on others, you can write them down. There's got to be pens around yourself.
Yes.
You can write them down if you have specific other things that we didn't think about with putting these sheets up. Just write them down and then put your dot on the other.
Member Harper was the before, after, and PM plan. Okay. Sorry, that wasn't clear initially.
Okay, so we just deal with.
Yeah,
Yep, so there's,
literally the floor is yours.
yes, there's
5 sheets.
5 sheets, there's 3 here and 1 on each side of the room. So you're gonna get your steps in today.
I'd like to see member Joy walk around halfway.
I'm gonna be member Joy once she sends me her things. Yeah, I'm sorry.
That's what I said.
You won't hear it. I told you it was crooked. Thanks, Jen. Did she drop them in that chat? Because she might still be looking, but I sent her my own.
Yeah, it looks like she dropped it in.
Okay, I'll come look at yours.
That's very nice of you to say, and you're allowed to change your mind if I don't agree in the afternoon. You could put it down on my hand.
Sorry, Amy.
No, unless you want to. This is.
By the afternoon now.
Something about female coordinator.
Yeah. She says she's good.
Yeah. Sorry.
Really quick question. Is Kaiser now part?
Yeah, I think it's hometown health. I think they,
I mean, now has their own life. That's,
yeah, I haven't heard. It could be, I
I know
haven't.
it's active. Kaiser's gonna be active.
They may be
I'm just
contracting.
trying to see what the difference is.
Yeah, they may be contracting with Renown, but
What's the difference between Siegel and the other group?
we're just different consulting firms.
Oh. You like them?
That's up to you, sir.
Like each other?
Yeah. Yeah. Gonna remove that.
It's not gonna help. It won't work.
I'm sorry, we gotta be.
Ah. Supposed to be small. We're supposed to get small. All of them together.
I love it.
I was in training those days.
Pac-Man's also involved.
To be in a disease management program. So GLP-1s are on a couple of different times. So this is a good, making sure you get accounts and stuff, making sure you have. But we'll go through all that. How we doing?
Right?
So, so far this is going well because we're ahead of schedule. I don't, I'll take that as a good. We had pre-designed a break at this point to kind of go along, but that seemed to go well. I'm going to propose that we keep going. And it's 10 to 10, that we're going to give ourselves a guideline of 10:20 for the presentations and then see where we go in the discussion.
Great.
Following that. Okay.
Wonderful. So thank you. So it looks like a lot of folks are interested in consolidating of the existing plans, expanding HMO access, and we had a vote on full replacement. So what we're going to do in this first slide is kind of give a little bit more guidance from our perspective on kind of potential savings and horizons. And we're going to do that like time horizon that it would take to implement. So we're going to do that as an introduction when we get into each of the topics. And then we'll give you some background information to help guide discussions with the board. So full replacement, depending on how you design plans, can be little to kind of, meaningful savings. And again, depending on how fast we want to go, it's probably a 1 to 2 year horizon. The consolidation is probably, minimal to kind of could be middle of the road kind of savings. And that is something we could do within a year. Deductibles, which no one, I think, had interest in to historic levels prior to buy down, is probably providing minimal savings, but it does give directionally, I'll just say directionally, it kind of can change some of the member behaviors as well. And then we'll talk about expanding HMO access. Okay, so I'm sure you all familiar with this. This is your current plan designs, your consumer, kind of on a high level plan design options. Your consumer driven health plan has a $1,700 individual and $3,400 family deductible. With 20% current co-insurance, the max out of pocket is $5,000 for individual and $10,000 for family. There is what's called seed money here of $700. And then looking at, and this is just the in-network side. Your low deductible PPO is at $300. That's effective 7/1. $600 for family, 20% co-insurance as well. The out-of-pocket is similar to the consumer-driven health plan. The EPO is $100 deductible. 200 family with a 4,000 and 8,000 out-of-pocket maximum. It's mostly copay driven, as you can see as you scroll down the page. And then the health plan in Nevada is kind of goes in line more of the HMO kind of style, where there's no really deductible. There is some deductible on prescription drugs. There is out of pocket, but it's really copay driven on this plan as well.
Okay,
Yes.
Paul Davis here. What's the percentage of enrolled members for each group?
We'll get into that, sir. And we can go to that is on slide 22. Let's move to slide 22, maybe if we can.
Oh, sorry, I didn't.
It's okay. So on this side is the members who participate. So it's very close, 50-50. It's 42-41. So 42% are in the consumer-driven healthcare plan. 41% are in that low deductible PPO plan, followed by the HPM plan at close to 3,200 and the EPO at 2,500. So in total, about 5,500 in that EPO HMO option, and then splits. What we have found, and we have talked about in prior board meetings, if you recall, is the low deductible PPO plan has not been set to the actuarial rates that it should have, and particularly the consumer-driven health plan has subsidized that health plan, and so we're seeing members with more utilization, higher costs going into that plan. And that's what partially has got us to where we are today from a financial perspective. That to build up those subsidies, as Ms. Carson said, we're used to help subsidize premiums versus building up the reserves. This is showing while we're here is kind of the costs that we're seeing. And this is on a per employee per month basis. And this is for plan year 26. So we're showing it separately for medical and pharmacy, and then the admin associated with it. But you can see the EPO plan, the high dollar cost there. Number of retirees in that plan, and also just in general, older members with more chronic conditions are also on that plan. The consumer-driven health plan was also subsidizing the premiums on that plan as well, as we've talked about. And that's where that 30 million additional money for fiscal year 27 is needed to help kind of phase in those premiums. And then you can see the cost, this consumer-driven health plan cost is much lower, and we've seen a rise in the low deductible PPO premium of $1,200. So let's kind of move back. Is that helpful? Okay, great.
Very much, thank you.
Welcome. Okay, so on to slide 13. This is giving at the top, and this is important. This is the actuarial value. What do those numbers mean? The way I look at it is if you have $1 of healthcare dollars to spend for services, how much of the plan is going to pick up the cost of that dollar? So you have $1 of services, you're going to utilize services. The consumer-driven healthcare plan is going to pick up 78 cents of that dollar for spending of when you utilize services. Conversely, the EPO and HMO is about over 10 percentage points higher. They're going to pick up close to 89 and 91% of a dollar of the cost of the plan. And then kind of in the middle is the low deductible plan, which is at 83 cents of the dollar. So that's kind of a way to look at it. These and highlights are the changes that you made effective plan year 27, which was about a $5 million or about 1 percentage point in savings. If we go on to the next slide real quick.
I just ask her.
Yes, absolutely.
Actuarial percentages, are those actuarial percentages adjusted to reflect the changes that were made in December?
Yes.
And but the premiums don't factor into that, or they do?
The premiums do not factor in that. This is kind of based upon the plan design. And if you utilize services, how much would the plan pick up when you utilize the service? It doesn't reflect the.
So I was curious because it's the 26 premiums with the 27 plan design. And I wasn't sure why.
That's correct. We had, because this was a prior, we did this slide in the January PED presentation. So that's why, because we hadn't finalized things yet. So you'll see, and that's a great call out. A lot of our slides have been presented in prior board presentations to just kind of, we've summed up a lot of things for prior board presentations, but you're right, it's not the 27. Okay, so these were the premiums back in plan year 22, or I'm sorry, this was the plan design back in plan year 2022. I want to point you to the low deductible plan. The annual deductible was $500, right? And then there was excess funds within the plan as a result of COVID, and that money was used to reduce the deductible as well as some other things, but primarily that deductible. And so we did increase that for plan year 27 to 300. So if you go on to the next slide, we did an analysis. This is from the January PEB board meeting. And so this is included in the packet. We did an analysis to say, okay, here's the plan designs for plan year 27. If we took plan year 22 plan designs and trended them forward to plan year 27, what would the plan design look like? Well, the 300 would be at 600. And so, and you can see further down that like the 1700 would be 2100, and the deductible for the EPO would be close to 200 versus the 100 that it is today. Yeah.
Just for clarification purposes, if the 500 and the LDPPO had been restored like it probably should have been, then that trend would have been higher for 27, correct?
Say that
It
again.
wouldn't have gone from 300 to 600. It would have gone from like 500 to.
That's correct. And I think no one really voted on this, but we wanted to have this slide available to say if, you know, kind of just from a perspective, you know, the benefit has become more generous than it was originally implemented. Yes.
So does that mean, and this may have been in an earlier presentation also, but the actuarial value of the plans under the 22 design, were they similar to where we are today, or were they lower than where we are today?
For the LDPP, it's lower.
Today or 22?
Lower than, so no, the 22 actual value would have been lower because it was at 500 versus today it's only at 300. So the actuarial value would be lower. Yeah. Good question. So the bottom line is that, you know, your plans have trended. I think the outcome of this, your plans have trended up. PEB has picked up the cost of the trends, right? Like, and again, some of that cost has been shifted over to the employees as premiums, but there's been subsidization as we're coming out of that. As you know, that's part of the $30 million. That, you know, some of the plan designs have not kept up with trends by making changes. And so as a result, the plan picks up more, and then theoretically more dollars are going through to increase the premium to cover the cost of the plans. I hope that makes sense. Okay, let's go on to the next slide. So we're going to go into some benchmarking. I'm going to do about 1 or 2 minutes, and then I'm going to turn it over to Mary Ellen. So Mary Ellen, get ready. Okay, so we did just high-level benchmarking. Again, this was in the January PEB board meeting. We did high-level benchmarking of kind of Western states. What do other states provide in benefits? Let's go to the next slide. So we're comparing the low deductible PPO at the actuarial value of 83%. And we looked at the leanest plans and then the more generous plans around 93%. So your low deductible plan is a little bit more generous than the average benchmark of Western states. Go on to the next slide. The consumer-driven health plan is more generous. Similarly, did the richest and the, I like to say more generous and less generous here. Anyway, but the consumer-driven plan at around 78% actuarial value is providing more generous benefits than that we're seeing in other states on average, based upon the average benchmark data of the Western states. And Siegel does, we are the consultant to a number of these states in the West. I'm going to turn it over to Mary Ellen. And so there was a question by a board members. What does Siegel do versus what does Mary Ellen at Milliman does? So Siegel's the actuarial consultant for Nevada PEB. Milliman was hired by the health authority to do some strategy work. And so we've been collaborating together on this project for you today. So I'm going to turn it over to Mary Ellen, who's representing Milliman, to go through some slides. They've done some benchmarking on a local basis within public entities within Nevada. So take it away, Mary Ellen.
Thank you. Can everyone hear me okay?
Yes.
Perfect. All right. Quick introduction. My name is Mary Ellen Vargas. I'm a senior consulting actuary with Milliman. Debbie did a nice job, I think, teeing up the kind of partnership that we have here, but my team has been engaged by the health authority to provide a strategic assessment across programs that the health authority oversees. So Medicaid, the Nevada Exchange and Public Option, as well as PEB. And my background is working with employer groups on all things strategy, pricing, actuarial. So we've been working closely with Siegel in preparation for this meeting. And I've also been working in conjunction, obviously, with my team on some of those cross-program initiatives. And we'll talk a little bit more about those shortly here as well. So in terms of this benchmarking here, we have similar detail to what Debbie just walked through for the state comparator plans. We have similar kind of plan design detailed level tables in the appendix. So happy to flip to those if that's helpful. But just taking kind of a 10,000-foot view here of what's happening in the local market. A few highlights that we wanted to point out. So we gathered information from 5 local comparators, being Washoe County, Carson City, Clark County, the Clark County School District, and then the City of Las Vegas. So those were identified as kind of key local comparators. Maybe these are entities that, you know, if PEB is potentially losing employees or competing for talent, these are some of the target entities that a lot of the same talent pool is, you know, maybe floating between or considering positions between. Of those competitors, all offer between 2 and 5 plan options within their employee benefit programs. So PEB falls right in the middle of that benchmark, right? Technically, there are 4 plans, but really depending on where people live, they have the choice between 3 different options. And then we list out there in the sub bullets which of the benchmark entities have 2 options versus 3 options. City of Las Vegas is a little bit of an outlier with 5 options. So I would say, you know, PEB really does fall right in line with the benchmarks, but we heard from your initial flagging of opportunities or ideas that, you know, you think might be viable. Consolidating the options down to 2 would still keep you in line with those local benchmarks. In terms of networks and administrator partners, 4 of these 5 local comparators are partnering with UMR, Health Plan Nevada, United Healthcare, really all falling under the same umbrella that PEB is under today. The one exception is Carson City, who partners with Prominence at the local level, and then Prominence's national partner is Cigna, for those not familiar. And then we did note that for the 4 entities that partner with United, UMR, HPN, all of them do leverage the Sierra Care Options Network for at least one of their plan options in the southern part of the state. So again, aligned with PEB's approach there. Types of plans offered. Each of the 5 entities has at least one broad PPO option. 2 of them offer high deductible health plans. 4 have at least one option that's either an EPO, exclusive provider organization, an HMO, or a point of service POS plan. 3 of the entities have at least one option that has a tiered network, so steering utilization via more competitive plan design and cost sharing to certain providers. And then, oh yeah, sorry, is there a question or a comment?
Nope.
Okay, sorry. In terms of premium contributions, we weren't able to gather information from every entity, but of those that had information available, we want to note that 3 of these 5 have employee-only premiums that are 100% subsidized. That's City of Las Vegas, Carson City, and Washoe County. And then for members of the Teachers Trust under the Clark County School District, those employee contributions are not 0, but they're very low, less than 5% of the premium. On the dependent side, there's a bit of a wider range. So where information was available, those dependent subsidies ranged from 25% to 60% of premium. And we break down, which entities fall kind of on either end of the range there. In terms of key takeaways, our observation, I alluded to this already with kind of the number of plan options, the types of plans that PEB offers, the vendors that you're currently partnering with, those do all seem to align pretty closely with what these other entities in your areas are doing. We think there could potentially be some opportunities under 3 kind of subtopics. So premium subsidies, there's a bit of a distinction there with 3 of the 5 local comparators subsidizing employee-only coverage at 100%, but offering a much less significant subsidy for dependents than what we're seeing on the PEB plans today. So something to consider there. Tiered networks may be worth exploring further. We'll talk in a lot more detail about contracting, as Debbie mentioned, and provider network partnerships, but potentially implementing plan designs that have different tiers and steer utilization towards more efficient, cost-effective providers could be something that we explore further. And then we've touched upon this already, but the number of plans, right? So it does sound like there might be an appetite to explore some plan consolidation. And if PEB did move from 3 options to 2, again, depending on where folks reside, that would still align with these local benchmarks. And then we just put some summaries together on these next 2 slides. Again, I'm happy to flip to the appendix and show any of the detail for plan designs if that's helpful. But kind of going off of the theme that Debbie just walked through on actuarial value, this table compares just as a baseline using the PEB LDPPO and shows what the difference is in actuarial value between that and all of the other plans that we benchmarked. So you can see, pretty squarely falling in the middle there in terms of PPO, but I will mention, we count in this mix of PPO plans, the point of service POS plans, as well as high deductible plans. So kind of unsurprisingly, a number of the high deductible plans are leaner or offer less generous benefits than the PEB LDPPO. And just to orient you here, the negative numbers, the bars in green kind of below the circled plan, those are plans that are less generous than the PEB LDPPO. And then plans with a positive percentage that have a blue bar, those plans are richer or more generous than the PEB LDPPO based on actuarial value. I'll pause and see if there are any questions or comments.
So during the pause, I'm going to give we have 10 minutes left.
Yeah.
In this segment.
Yes.
If that works.
Let's go quickly through the next slide, Mary Ellen.
Yep. So similar story here. I don't think we need to spend much time. This slide just compares the HMO and EPO plan options, PEB versus those local comparators. Interpretation of this slide would be the same. Green negative numbers implies a less generous benefit. We chose the PEB EPO as the base plan here. And then those blue bars would be more generous or richer benefits.
Great. Thank you, Mary Ellen.
Thanks.
All right, we've already gone on this slide. The rest of the slides in this section just provide what the plan year 27, to your point, board member Chris, kind of what the premiums are for plan year 27 for your reference. I'm not going to go through those right now because I think let's open it up if you're good. Yes, question.
I'm sorry, I just had a quick question for Mary Ellen.
Sure, Mary.
Why do you feel Washoe County is such an outlier?
Go back to the other slide. There we go. Are you talking about Washoe County PPO being 10% higher?
Yes, I'm taking a peek at, oh, go ahead, sorry.
I'm sorry, what?
The question, Mary Ellen, is why do you think it's such an outlier? What's driving that 10 percentage points more?
Yes, so I'm just flipping ahead in my deck to the appendix slide. I think it's primarily driven by a lower out-of-pocket maximum. So their out-of-pocket maximum looks to be
We're gonna pull it up.
What so I'm on, I think it might be slide 77. But so the PEB LDPPO out-of-pocket maximum for a single is $5,000, $10,000 for a family. Most of the local competitors are around 6,000. Some are at 6,500 for a single. But the Washoe County PPO has a just under a $3,500 single out-of-pocket maximum, which is significantly lower.
Pharmacy is more generous. The copays are lower as well. Look at the difference in ER. Again, with the 20% coinsurance, but you're at $750 copay.
I see.
Yeah.
The big one's the out.
The big one's the out-of-pocket max.
Yep.
For sure. And family 6,900 versus 10,000. Yes.
Wayne Harper for the record. Does the actuarial value include any cash that is available on the high deductible plans? So, for us at PEB, it's the 700 at the individual level. I think that there are some of these plans that offer a larger amount.
Yes, the actuarial values do reflect any seed money that the employer gives. And actually, if we flip to the next slide, that's outlined for the two entities. We weren't able to confirm for Carson City, but Washoe County does give a very, very generous amount of funding for the HSA contribution. Admittedly, that's much higher than I would say we typically see in the employer.
Yeah, agreed. Very generous. So basically their deductible is essentially covered and half of the out-of-pocket maximum. That makes it incredibly generous plan. Yes.
Laura Rich for the record, do we have premiums to compare here too? So, I mean, I know they're offering richer benefits, but what are they charging for them? Are they subsidizing them or are they, what is that? Because I think that makes a difference. You can offer whatever it is you want to offer, but someone has to pay for it. So are the employees paying for it or is the employer paying for it?
So for a few of the plans, we had exact premium information. More often than not, it was kind of higher level. Premiums are subsidized at X level. I will say Washoe County is one of the three that does fully subsidize employee-only coverage. So employees, when not covering dependents, don't pay anything for premium for these plans. On the dependent side, though, the subsidies seem to be significantly less generous for these local comparators than PEB. So on average, we saw about a 50% dependent subsidy from the employer for most of these plans. And PEBs seem to range from, about 20 or 60 to 80% subsidy.
So something to think about here, right? And board members is that how you're subsidizing the plans, right? Employee versus dependents, and that's probably a good discussion as well. Any other questions before we go into discussions?
So can I ask, just to make sure I'm understanding the actuarial value again from my prior question?
Sure.
The actuarial value is not, it doesn't differentiate between the employee contribution and the employer subsidy. And so a portion of that 80% actuarial value is being funded by the employee contribution.
Yes, that's correct.
So when comparing to benchmark averages with different employee contributions, the employee value, the employee value of the plan may be different, even if the actuarial values are the same, if their contribution is higher or lower.
Yes, the actuarial value, yes, the actuarial value plan is slowly looking at if they're utilizing services based upon the plan design, what percentage is going to be covered by the plan. It doesn't take into consideration any contribution, subsidization on the premiums. That is true. Yes. That is correct. Okay. Where do we go from
Hey,
here?
Andrew Sherman standing back up. So, we're 2 minutes ahead of even the advanced schedule, so we're doing great, meaning lots of time for you all to comment or share ideas if you'd like. Here's where we are and the way we've set up the structure. Plan design. These were the 4 ideas. We didn't have any other ideas, but there is still time for other ideas if you want from what you've heard. Initially, we heard, we see from your dots, most interest in the consolidation of the existing plan options, and you've seen a lot of benchmarking data. There's a lot more on what others are doing and what that might look like. Some interest in expanding HMO access, looking at other HMOs. One dot on full replacement to a single plan, and again, to differentiate, full replacement is kind of very dramatic. Consolidation is more flexible. Return deductibles to historic levels. So you saw some trending forward of information, meaning that the plan that you have today, if it just trended forward for inflation, the plan is paying more than the participants. So the participants have gained a little ground. They're paying a little bit less than they would have paid if inflation was applied. Now, no one thinks about it that way because they think about the actual dollars they're spending in a deductible. Okay, the floor is yours. Observations, comments, things to share.
Laura Rich for the record. So I think one of the things we were just talking about is, we've seen the benchmark of the plans and what, where we stand in terms of what we're offering our employees. But I think what would be helpful to see is benchmark of what board member Chris was talking about is, what do states and probably more importantly, the counties, all of our competitors really for workforce, how much of the employee benefit are they paying, right? How much are they subsidizing? What are they, because that's really what it comes down to is, where we stand and with our local competitors, because we lose employees every day to the counties, and I know there's more to it than just the benefits, but they can pay them a lot more as well. But understanding where our benefit structure stands in terms of how much we're subsidizing employees.
So what I'm hearing you say is the actual value is a way to look at what the design is.
Yes.
That is important. But from the perspective of competing for employees, which you're doing, and all your contributing employers are competing for employees every day, the potential employee or the current employee looking maybe at other opportunities is seeing premium. We haven't really captured here what that premium looks like and understanding that major adjustments to the premium might have a more immediate impact because people aren't thinking about what the actual design is until they're utilizing services.
Okay, for the record. I'm also considering like the concept of value, right? So the connection between the premium and the service offered. Have we done, is that in one of these 118 slides that I just haven't seen? Have we, because like we can say that maybe we, you know, they want to go to this other county plan because of whatever reason, or their premium's lower. Is their premium lower and they're offering better, you know, medical value, or are they like, is there some balance or comparison that has been done there as well?
So Member Duncan, I hear you saying, is there a way to look at value of coverage and cost to the member?
Yeah.
Okay, now because there's also cost to the system. So PEB is paying the cost, and that can go up or down based on what you all decide, but you'd like to kind of see that more side by side with the value of the actual plan, right?
Yeah.
Repeating what you're saying?
Yes, you're repeating what I'm saying.
Appropriately, okay.
For the record, I just think, go for it, Debbie.
Point of clarification, I want to make sure I understand your definition of value. That's different than actuarial value. I want to make sure I understand what you mean by value. So
Yeah.
we give,
Yeah, that's fair. Okay, for the record, I think, you know, we have a fiscal issue, right? And that's what we're trying to solve for. But in solving for that, I don't want to lose sight of like the actual value that the plan provides for our recipients as well. And just considering if there's a comparison or
other than actuarial value.
Is it maybe some
Other
kind of net?
other than.
Some kind of net number would be interesting.
I think it is.
Trying to
Would
figure out
service
what-
quality be a way of describing that, like the quality of service or the quality of the plan, not just the dollars? So-
Yeah, Laura Bridge for the record, I'm actually on a board of one of these plans. And we actually have another board member who runs that plan, and they offer a lot of kind of, you know, really unique perks for their members, right? They have, you know, if you want to enroll in a certain kind of like a value-based care plan where you can, you enroll through a provider who that provider then kind of, you know, provides you the care through their, you know, network and you get certain things free that way, right? Like, you know, certain things that you would normally pay for if you didn't use that provider, you'd have to pay your out-of-pocket co-pays. But if you're using this kind of system that they've got, then you're getting free benefits for, you know, X, Y, and Z, right? And so they have like different things like that are kind of neat and unique. And I think that brings a lot of value to their members that actually, you know, participate in all of those, depending on what it is. Yeah.
I see, Member Harper next.
Blaine Harper for the record. I think finding a way to provide comparable benefit, taking into account premiums on the participant side, would be a helpful direction. To the extent that there's an issue with losing people to city and county versus state employment, I don't think that there's anything in the scope of just the PEP board being able to change that dynamic, because the PERS contribution rate does not affect these comparison cities and counties for employment. Whereas, you know, right now, the sticker price of all our salaries in state service would be, you know, what, 10 percentage points higher if we weren't paying PERS out of our paychecks. So, you know, we can become comparable in terms of healthcare coverage, but in terms of comparable as, you know, competing for state employees, there's a bigger picture.
I'm going to pause just for a moment to try to make a couple of connections, if I can. Because I think that what some of you all are referring to, we're gonna cover under what we're calling composition of the risk pool, but here we also really kind of get into the premium part as well. So I was trying to come up with, is there something that we should add here as an other, which I open up if someone wants to add something now, but also maybe we just put a pin in that until we cover the next topic.
And I would add, for the record, Debbie Donaldson, Siegel, remember, Rich, I'm wondering if you're talking more of like 3-tiered networks, right? If you go to a tier 1 doctor, you get additional perks because you're using, they're better contracted. They have better contracted rates and there's an incentive for the members to use those because they tend to be higher quality, they're contracted at better rates. That is certainly something we would want to consider, I think, to your point, in contracting procedures as well. I still want to address Dr. Duncan's, like, is that what you mean by value? I want to make sure, as we think through things that we're addressing that appropriately.
Yeah.
Okay.
For the record, I think that's really what it is. It's value that like the nuance to it that may not necessarily be reflected in an actuarial.
Gotcha.
Yeah.
Okay, thank you. Very helpful, thank you.
Member Davis.
And Andrew, Paul Davis, I think it's important to distinguish the type of employees between these comparisons. For example, I represent higher education. People move quickly if they don't like the medical plans. And that's a key point. I would think, I could be wrong, that state and county employees probably don't have that option, or generally don't have that option that higher education individuals do. So I think that's important to distinguish.
That's a very good point. I think you're just adding, to try to repeat back, you're trying to, you are, I think, clarifying member Rich's comments about competition, that competition is actually more multidimensional for employees because of difference. So, member Barnes or member Vitten, did I say that right? Good time. Any comments?
Not at this time.
Oh, fair? Okay.
I guess maybe just in terms of the topics that we have under plan design, and the way I'm thinking about them. Fully replacing with single or multiple is talking about or changing what options are available, right, to the participants to select from. It could be the same number, it could be fewer or more. Consolidating is definitely reducing options. Returning deductibles is reducing benefits. Expanding HMO access would just be providing a new option in the north. That's what that item represents.
Potentially, but there's other options.
Or another HMO.
Or another HMO. Yeah.
So I'm just trying to understand, like some are very clearly, and many, we're talking cost containment. So most of the things we're talking about are reducing benefits.
Can you go back to the slide with the dollars and the?
Yeah. And to kind of set the stage, to save money, something.
Kind of change.
Yeah,
But some
yeah.
are reducing benefits. Some of the things in the contracting are more aimed at cost containment.
Yes.
Without necessarily reducing benefits. And I think
Or narrowing the network.
healthcare cost and healthcare benefit
Yeah.
are in some ways the same thing, right?
Yeah.
We pay for a benefit. So reducing costs somewhat necessarily translates to reducing benefits unless it's reducing the margin on the providers.
Yeah,
Suppliers.
that's correct. Or narrowing the network and only going to high performing, which you get noise sometimes too, because members then.
So I want to really just underline what you're saying, because I think it's those are some very valid points, but I want to turn back to your actuaries, my direct colleagues and our other colleague, Mary Ellen, if they want to react to what you're saying in any way having to do with consolidation of risk pools and how that overlaps with the number of plan design options.
Yes, so depending on how you consolidate, there could be savings, right? To the point where, depending on how those get consolidated and what the value of the plan is, there is savings, right? I think what I'd like to hear a little bit more is some folks' thoughts about what does that consolidation look like? Like what are thoughts around, a lot of you guys voted, not voted, I keep saying voted. You guys put your stickies at consolidation of existing plan designs, and would love to hear the perspective of you all of what your initial thoughts are around that. What does that look like from your perspective? Yes.
Paul Davis here. I put dots down, not necessarily saying I'd advocating that. I wanted to see what the consequences, what the cost would be to the members and the value that we receive. So I
Member
just don't.
Davis, good job at following instructions.
I just didn't want you to perceive that just because we have the dots there, that means that we are advocates of that.
Okay.
Does that make sense?
Yes. Yes.
So for me, looking at Washoe County on slide 19, you've got the richest plan at 10.4% over our base, and you've got their high deductible at 0.5% below our base. Pure differentiation between plans. We don't have that. We've got a couple percentage points between plans. Not that big difference that you see in Washoe County. Washoe County also requires you to be on the CDHP for the first 2 years of employment before you can pick any of the other plans. And then they pay the employee share only, and then their family and dependent costs are significantly higher than what ours are for similar plans. And so for me, that's kind of what this whole consolidation plan is really about, is making differentiation between the plan designs that we offer to our employees and then the respective premiums that they pay to get those benefits. Because you pay one way or another. You pay when you use services, or you pay in a premium upfront. That's kind of the gist of how health insurance really should work. Is you're not supposed to be able to pick the plans that minimizes all of your out-of-pocket costs. Because what you get the enrollment, there's a name for it.
Migration.
No, not the migration, the adverse selection. So you get the adverse selection. People look at something and say, well, I'm gonna have, I know I have to have a knee replacement or a hip replacement, next year, or I'm gonna have this major event, accidents and some of that stuff, much harder, but there's a lot of things that can be planned. Or I know I'm gonna have to start taking this medication. I'm gonna switch to a plan that has a copay for my medication, because I don't want to pay 20% of it anymore. I want to pay $10, or when I go to the pharmacy or whatever it is. And so I think that we need to look at, for me, when I think of the consolidation of existing plan options, is a wider differentiation between the plan options, and then a wider difference between the premiums that you pay.
Just a real quick comment, a 2-year waiting period would be absolutely devastating to higher education. We'd never be able to employ anybody full-time on a 10-year track. They just wouldn't put up with it. Not a 2-year waiting.
They're not a waiting, they have to be in the high deductible health plan for the first 2 years. They can't pick one of the richer plan options.
Oh, I thought you said
until,
they would.
No, they can't pick the richer plan options until they've been employed there for a minimum of 2 years.
Oh, thank you. I misunderstood.
So we are at that sort of time that we've wanted to allocate for the first topic. I did want to make sure that Mary Ellen, that you wanted to react to anything. I'm giving you this chance now.
No, I think this has been a great dialogue, and I was going to chime in with the point that Chair Wells already made. So thank you for raising that. We did find in our research about the requirement for Washoe County to be on the high deductible plan first. So definitely something to consider, and not something that appears to be the norm for any of the other comparators that we benchmarked against, but just a consideration.
And just to add, I think one of the things we're looking for is direction from the board. Are there considerations that you would like us to take back and price out and present for future board meetings? Like, is there interest when you say consolidation to President Wells's comment? Are there things, should we be looking at some plan designs and what that would look like from a premium perspective, from an actuarial value perspective in the consolidation? So looking for a little bit direction of where to go next.
Member Harper.
Kathleen Harper for the record. As the lone full replacement thought, I just want to clarify that it's consolidation related, that if there was a wholesale different HMO option, it's not split cut south, or it's a different, if Kaiser or, whatever's different about it, but, it's kind of a consolidation idea, but the HMO option, it has been one of the trickiest things that happened. And, a full replacement of the HMO option is what I'm thinking in terms of for that.
Thank you. Thank you for that comment.
So from a facilitation standpoint, I want to remind you that we've done 1 of 5. We're ahead of schedule. I want to also recognize that this is not a typical board meeting structure. It takes a different kind of energy to do this. So I wanted to, at least through Chair Wells, ask if people feel like they want to stretch their legs before we go into the next section. Because it's like I said, it's you're using your brain differently than the normal course of business. So I want to make sure we're thinking, and there's snacks. Are these snacks?
The candy is a snack, the chips go with lunch.
Okay, you can only have candy then. All right.
One second, real quick.
Sorry?
We break.
Just because I'm from New England, they thought I brought lobster. You can buy it at the airport.
Can you real quick before
Sure,
we
of
break?
course. I'm sorry.
So I think the idea behind this is to kind of get the thoughts. By the end of the day, we have to kind of give the actuaries some actionable stuff for them to bring back in future board meetings for us to take action on. So while you don't have to say anything, I don't think right now.
Yeah.
I think where you put your dots for the afternoon are going to be telling as to what kind of things that we bring back to future board meetings for real decision making.
Thank you.
It's 22 of, 10 of, 5 of.
I don't know how hard it is to get to the restroom and stuff here, so let's do.
You just have to go back and give us back.
Want to say 5 of at least?
Let's say 5 of.
5 of.
I was gonna say 7.5.
Oh, that's actually,
The meeting back to order. Turn it over to Mr. Sherman.
I'll give it back to Debbie.
All right.
Thank you, Chair Wells.
Yes. Thank you, Chair Wells. We're going to move into the next topic, which is the risk pools, consolidation of risk pools. We got a lot of dots kind of everywhere, so we'll kind of go over these. We already talked about dependent subsidies a little bit when we were comparing plans. We'll talk a little bit about that. And this again gives you a high level of potential savings and time horizon. So separating the actives and retirees from the risk pool and rating them separately, depending on the direction and how you go about it, can create some savings. And that's a 1-year horizon. That's something you can do fairly quickly. Moving the non-Medicare retirees to the exchange can also save you money as well. And we can talk more about that. That also helps to reduce the OPEB obligation, which is the liability that they have to put in financial statements associated with the liability associated with the kind of total value of the retiree health offering to retirees. That's probably a longer horizon, 3 to 5 years. Dependent subsidies can give you some savings, and depending on how you reallocate those subsidies, and that's something that you could do fairly quickly within the next year. So let's go on to the next slide to kind of dive in. This is just giving us a high level perspective. What we've done here, and I've got some numbers for you as well, is look at the plans, look at the membership, and I'm going to go through some of these quickly. But looking up here is that these are the actives in the consumer-driven health plan. We have about 19,300 members in that plan, and the per member per month cost associated with those members is about $513. And this number, which may be hard to read, is that trend from last year. Claims only increased about 2.4% for this group. Let's flip to the next slide in comparison and look at this slide where we're looking at retirees in the consumer-driven health care plan. And again, the rate that we're showing is now, that 500 is now $953. And in addition, we're looking at the number of members is about 2,400. So less retirees per se, but the costs are meaningfully more, not double, but probably 75–80% more than the cost of actives. Going on to the next slide, we're looking at the low deductible plan. The per member cost for this group is around $675. The trend for this went up 14.4% from last year. And as Chair Wells noted, we have seen in the plan, to Chair Wells's points, when members want to utilize care, we've seen migrations away from the consumer-driven health plan into the low deductible health care plan to utilize services. We showed in the May board meeting materials, there's higher utilization of services in this plan, but your out-of-pocket maximums are the same. So if you're going to be a utilizer of services, you're going to go into this plan, right? And the premiums were not set such that it's fully reflective of the underlying risk profile. You're going to go into this plan because it was subsidized and utilize it. And then when you're done utilizing care, jump back into the consumer-driven plan. We've seen that happen in your membership. You have about 21,700 members in this plan. Let's flip to the next slide. Look at the actives. Costs for the retirees, costs for the retirees are over $1,000, almost $1,100 for this group. You do have smaller number of membership, which is around 1,400. On to the next slide. Last but not least, the EPO. Actives, the cost for this group is just under $1,000. The trend for this was about 6%. We've got just shy of 4,400 members in this group. So more expensive than the other two plans. But look at the retirees. We're close to $1,600 per member per month. That cost went up for the retirees almost 14%. We have about 560 members in this plan. So when we looked at, I think it's on the next slide. When we looked at and we separately underwrote each of the populations, we looked at actives and retirees. Right now, again, they're blended into one. So if we break them apart, the active rates would go down approximately 5%. That's about a savings of $15 million because it's a bigger membership, even though the percentage is going down smaller, bigger membership. The retirees are going up 32% to reflect the true cost. That's saying in general that the actives are subsidizing the retirees by about 32% in general, or about 37% really, that's the true differential. And the cost for that is an additional $17 million. That increases the cost by $17 million. Now, we did this based upon 2025. We're working on some budget projections for the biennium. So these could change slightly once we get the migration and all the movement patterns that we've seen as of July 1. But we were using the data as of December 25. So this potentially may tweak a little bit once we get the updated migration. Yes.
But wouldn't that make sense? Because compare the average age of the actives compared to the average age of the retirees. Of course, it's just going to be more expensive.
Yes.
No, I'm just going to say, but
yes,
they spent that many years working in the system. You should expect to be having it.
Yes, we expect it. Yeah, absolutely.
I just don't want it to be perceived as an automatic negative.
It's not a negative for sure. It is expected. And what we're trying to show here is the true cost of the retiree rates if we were going to separately underwrite this group. You are correct. Any other questions before I move on?
Not a question, Laura Rich for the record, but I just want to, just for the board to understand that the retirees are non-Medicare retirees. So we're not, for the most part, we're not talking about, you know, the 85-year-olds, right, with very limited income, right? We're talking about those people who have retired at 55 or, you know, and probably have other sources of income and other employers, you know, a second employer. So there's a small group of people that, you know, that will never have Medicare and is, you know, will always be those. And I don't know, Debbie, if you have that number. It used to be something like 1,000. It's probably way less now. You know, there's a group of retirees who will always be on our retiree plan regardless because they're never going to be eligible for Medicare, but that's a small group. Most of these people are under 65, have retired early, you know, at 50, 55, 60, whatever, and are likely working a second job, you know, working another job with access to healthcare elsewhere.
For the record, I'd like to add, like, I'm aware of retirees who are not retiring earlier than 65, but have dependents they enroll or plan to enroll in PEP for. And, you know, so, you know, if two people are married and there's an over under age 65 situation, odds are, that situation comes up fairly often. Is it, so I guess my question about people who are retiring younger, potentially taking a different job, are retirees who have employer-based health insurance available eligible for PEB?
Yes.
In the eligibility for enrolling in PEB as a retiree, if you have your own employer-based health insurance, are you still eligible to choose PEB as a state retiree?
Yeah, once you retire, you can take retiree coverage and you can just stay on it, even if you have access to employer-based coverage from a second job. But the law also says that you can take that other employer-based coverage while you're working, and for one time, you can cancel your retiree healthcare coverage and then reinstate it when you leave that job. But that's a one-time, you can only do that once. I think that's the way the law used to read. I don't know that it's changed, but the law says you can reinstate one time. So you could leave and if your employer-based coverage was great and you wanted to use that while you were working, you could cancel your PEP coverage for as a retiree, have that second employer's coverage while you're working for them. Then when you stop working for them, you just basically re-enroll in PEP coverage for whatever you're eligible for, whether it's the pre-Medicare or post-Medicare.
So a person, when they do retire, they keep telling us, higher education, that you have to go to Medicare. So you're saying you
When
don't,
you're 65, you have to go to the Medicare exchange.
so there's no way anybody could stay on it.
Unless you have a, under 65 dependent. That's what Member Harper was saying.
So once you're 65, everybody goes to Medicare.
As long as your dependents are over 60. Current structure. And I think one of the big things for me, I don't know if you've got more that you want to talk about, but one of the big things for me is that, remember, if you were hired after January 1st of 2012, you can participate in a plan, but you pay 100%. And so this subsidy of retirees, in many cases, because we've got a lot of people now who were hired after 2012, are paying higher premiums for a benefit they're never going to see. And that's what, I think, to me, that's one of the things that bothers me a little bit, is that you're having these current active employees pay higher premiums. They're not going to see anything on the other end.
So, discussion. And can we go back to the,
Dollar sign.
yeah. So a fair amount of initial interest before we started on this separation of the risk pool and having the actives pay a rate where the risk pool is just actives and retirees pay a rate. And here we are talking about the non-Medicare eligible retirees who are eligible for the coverage and having them pay a rate based on that group's separate experience. Number two up here was to take this group of non-Medicare eligible retirees and direct them to the state exchange. And three was to look at the dependent subsidies, and this goes right into rate. How, when you set the rates in the various tiers, how much are the employees asked to pay for their dependents versus what is paid for by them? I get that right? So there's only three choices, but these are big topics for discussion. And at this point in our strategy session today, we're inviting your comments.
Laura Rich, for the record, just on the exchange piece, we did some analysis back in 2020 when we had to, because of COVID, potentially have drastic cuts. And so we did that analysis, and I don't know what that would look like today, but back in the day, there were winners and losers in that. People that lived in Clark County won, people that lived in the rurals lost, and people that lived in the Reno area kind of broke even for the most part. But with like HRA subsidies and things like that, you know, that I think that it could actually be, a potential good move, for retirees in general. If we did it right, it's something that, you know, we'd have to obviously do the analysis and, you know, and see what that looks like, but, in general, I mean, a good part of our population in Clark County would win.
So Brittany, because it's a strategy session, I'm gonna ask you to define win and loss. Winners and losers as you're putting this forward, making sure everyone's kind of on the same understanding.
In general, the cost of care, you know, what their premiums versus the, you know, the plans that they're enrolled in, their options. Just in general, again, people value things differently. You know, some people just look at premiums. Obviously, it's kind of a whole thing, you know, access, right? If you go on the exchange, you've got 80 plans to choose from. I don't know what it is now, but it's a lot of plans. And so you have a lot of plans to choose from. On PEB, you have 3. And so, you know, you have.
That's just what I was getting at. Yeah.
Exactly. But, you know, some of the deductibles are higher, you know, you may not have HSA options, you know, things like that. So it just, you know, but overall.
Maybe narrower networks.
Yeah.
I want to
Yeah.
pause. I think this, I don't know if you wanted to say something else, but I wanted to ask Debbie to talk about how the exchanges are rated.
Yeah.
Okay.
Yes, that's what I was gonna add. Great, thank you, Andy. So for retirees, and I've done this analysis for other states, when they've kind of considered and looked at this. All of those points need to be considered for sure, and what is defined in value. From a pure premium perspective, the exchanges have what's called a 3-to-1 ratio, but the highest tier, and the premiums are age banded on the exchanges. The highest age band cannot be more than 3 times more expensive than the lowest age band. That tends to benefit, at least in the analysis I've done for other states, has benefited early retirees. All things being equal, because of the 3-to-1 ratio on exchanges, the lower age groups tend to subsidize the older ages on the exchanges, and the premiums tend to be, again, I'm generalizing, but more generous or better for the early retirees. Actives definitely have seen winners, losers for sure. Early retirees, and then you have to consider narrow networks, multiple options, like all of those things are very important to consider. But from a premium perspective, many times early retirees win on exchanges because of that 3-to-1 ratio.
To make this conversation a little more dramatic. Oh, sir.
Yes, we had 2 more comments.
Oh, I'm sorry.
Wanted to, Keiko, Debbie, for the record. So just in summary, kind of what I was hearing from that, Debbie, was basically the problem that you see existing in exchanges in which the lower age groups are essentially subsidizing the early retirees is basically the same problem. Not problem per se, but it's like it's what's happening here as well. Is that my understanding? Okay. So
Yes, your actives are subsidizing retirees.
what I'm curious about then is
Not to the extent though.
So what I'm curious about is like what is that extent now? I think there is to Laura's point, you know, if we did this analysis in 2020, a lot has changed in healthcare since 2020 because of 2020, right? And so I would be very curious to see that analysis now and try to understand like the difference in those extents. Because if we find one that's more favorable to the budget and to the people at the same time, I think maybe that would help inform the decision. Yeah.
So, I'm hearing you say, and again, dots are not a preference for action. Dots are a preference for further study. That maybe you're guessing we might see a few more dots on the exchange for study, but we put dots up again later today. I don't mean to be putting words in your mouth, but that was kind of what you were saying.
Well, and just to add to that, we have retirees across the country, right? People don't just retire in Nevada. And so these are, potentially they can be winning or losing in other states as well. But again, be in Nevada or at PEB, we are focused on Nevada. We have plans that are Nevada plans that are, we look at our coverage for people that live in Nevada, our residents, our employees, and so our retirees do not necessarily get that benefit, right? Because we're not looking at plans in Connecticut for them. And so the exchange may be actually beneficial for, retirees because they're in a network that benefits them and they can choose a network that benefits them. So I just wanted to put that out there as well.
Clean record for the record. It's the case, 2 of our plans are nationwide, right? Yeah, not just statewide. So I guess I don't know as much about the plans that are on the exchange, whether those are state, sort of founded or, have many more nationwide options. Is that what?
Yeah, so Laura Rich for the record, if you live in Texas or if you live in Connecticut or if you live in Minnesota, they all have their own exchanges. We have Nevada HealthLink in Nevada, and so those are Nevada specific plans and networks and things like that. Obviously, you have national coverage as well, but if you live in Minnesota, then you're getting plans that are, Minnesota based with national coverage, right? And so again, our plans also have national coverage, right? But it's broad, right? We may not have, if we have a retiree that lives in another state, you may or may not have the coverage that they're looking for or that they need, right? Their provider may not be in that network because that's not who we choose. And so in this situation, it would be a benefit for retirees because they would be participating in their own state's exchange with their own state plans.
So,
Question from that then, because Kager for the record, I've never needed to use nationwide coverage before, so I'm curious if then, because they're out of network, I wonder how many in the retiree population are using out of network coverage and are therefore like that is a higher cost to care because it's out of network? Or is it similar or comparable to network? I don't know what the cost of is.
Point of clarification, Board Mayor, are you speaking out of network or out of state?
Well, both, I guess. I guess that.
I think she's saying since we don't, Laura Rich for the record, since we prioritize in-state coverage for the most part, right? I mean, we do have national networks, right? But we don't know where these people are living. And so potentially they want to use a provider that is not in our network. And so they go out of network.
Gotcha. So out of network are definitely more expensive. And we haven't looked to see how many retirees are using out of net. We can certainly take that back and look at it. The other thing I'll add is out of state in network is really dependent on UHC's network and how strong they are in that given state and given geographical area. It could be better, it could be worse. So I'll just add that component as well too, that it's really dependent on how strong that United Healthcare network is in other areas.
Take it for the record, and this might be a path we don't need to go down, but just my brain is asking questions of me. So if I wonder, I guess my next question is, okay, well, how strong is the network then? Which I think is some of our, provider contracting things that we're, so just how much is that maybe contributing to some of our, budgetary concerns, because they are truly out of network, it's driving up the cost of care, et cetera.
I wanted to underline, draw out a little bit of comment that was made 2 minutes ago, and just to re-challenge it to make sure it wasn't lost. And that's, as board members, you are responsible for actives, and you're responsible for this group of retirees. You're responsible for, I don't want to say promises made, but I'll say expectations of actives and retirees with limited resources. So you're really, this is really bringing to you this set of challenges of using limited resources for the employees, dependents, and for your former employees that would be eligible for this coverage. And those are some of the decision points. So I throw that out there if anybody wants to react to that way of expressing this.
So you want us to simply prioritize which group is more important than that?
I'm challenging you on what you want to look at, but in the most general terms, with resources that have limits and populations that you're addressing, how do you want to divide the pie? And what is your sense of, and this goes to observation was made earlier that we're competing for employees, or an observation that was made earlier about people in state versus out of state. We didn't even get to it if you leave the country in retirement. And these are the challenges. And what these are offering you are just some specifics. There could be others. But when you think about risk pools, and that's just the actuarial term for how you divide up the money, you know, and I thought of an extreme example to just hopefully add a little context for this, you know, and this is even before my time. But it used to be that plans were rated by the employee. And if you didn't have dependents, you paid the same or shared the same that someone that had 17 children, we used to say, right? And now at least we have a rate structure, and this is decades old, of employees that have coverage just for themselves don't pay the same as employees that have families, and then in your board tier combinations. So I share that not as a history lesson, but more of a perspective of this is not a new conversation for boards of health plans to think about who pays what. Any reactions to that? Just again, I'm trying to give you some framework if that's helpful.
Okay, Director, for the record, I appreciate that. I think we need to reframe how we think about that though, because I don't necessarily think, so yes, right, and kind of like multiple people mentioned when we first started this meeting, right, like there's give and take, right? I think, you know, we start with our intent, which is we have a fiscal issue that must be solved. How do we solve that? And I think it's not a consideration of who pays and who doesn't pay and where do we put the money. I think it's a consideration of, you know, Debbie, can you go look at our network? Let's see if this is strong. What's the difference between, you know, that same concern in the exchange versus that concern here? Will that close the gap a little bit further while still maintaining a high value of service for all of our recipients, right, across the board, retirees or not, right? And so I would really challenge that way of thinking, because I don't want us at all to think like that.
It was intended.
Quite honest, yeah. No, I get where you were going. I kind of start with this, like, what is the problem we're actually trying to solve? And that is we have a bucket of money that needs to be closed. And how are we going to do that? We're going to look through all of these different methods and say, hey, which one of these closes the gap the best while still maintaining a high value of service? And I think that's really the crux of what we're trying to solve here. So I would challenge us to maybe think that way, but that's my opinion.
No, I understand what you're saying, and I don't disagree. But I can see the pullback coming from groups saying, well, we simply we're the ones that are bearing the cost. I see a lot of that. So I'm a little bit confused on how I feel about this, but I understand we have to make these decisions. Someone's gonna be on the top end and the others are gonna be on the bottom end, but I think we really have to justify this.
Absolutely, I agree. Yeah, I think there's, can't go again. I think that, yes, I think ultimately, I hate the term winners and losers, but when we talk about subsidization, there are going to be groups that may or may not more or less subsidize the other. And the one that subsidizes them more, right? Like I completely understand that feeling. And I think no matter what we pick, I think us as like our deputy attorney general mentioned, right? Like we're all on these plans. And so I think all these decisions we make also affect us. And so having that strong data and that, assumption and having the correct information to be able to make the most important decision, understanding that it is truly going to affect the people's lives around us, including our own. I think that's just to say, like, when we're talking about the ways of thinking about this, I think, it's just a valid thing to consider. That's all.
No, I'd just like to say something. It seems to me, I may be way off base here. The fact that you said that many of us here are on these plans, does that not provide a conflict of interest? It would seem to me, I could be wrong, but I think many members would be looking to see, how does this affect me? I'd rather have an independent commission that are not under any of these plans look at this, but that's my own personal opinion. I just think how do you not look at your own plan when you're making these decisions? I guess that's what I'm saying.
Laura, Rich, for the record, I think this is why the DAG has that disclosure at the beginning. And the DAG may be able to weigh in on this a little bit.
Just said that.
Okay.
Sorry.
I'm sorry, Doug.
So yeah, just said that for.
Oh, maybe we come back.
I would say based off of the NRS statute, you guys are designed to look at that plan and vote and do in the best, fiscal interest of the state and the employees, which is why you've been appointed. I think if there was to be a change, that has to be effectuated in state law. So I think to the point of the disclosure that the DAG made at the beginning, that's why we meet every board meeting with that, is to say, yes, we know that you are all participating in one plan or another as a PEB member, and that you will likely be voting on matters that impact you or your family members. And that's why it's disclosed at the top, right? But I think the board was designed with the specialty positions that you guys are filling in each of those roles within state law. And so I think that's all been accounted for. And if that needs to change, that's going to have to be something that's outside of this meeting.
Well, I understand.
So I'm gonna.
Yeah.
I just not so 100% sure that in practice that. My comment.
I'm gonna pivot us back, because I would just want to offer the opportunity if there were other board members' reactions or thoughts on Member Duncan's very well placed comments.
Can I add maybe any other items to consider, or the board have any thoughts around changing how the plan subsidizes the employee versus the dependent? I don't know if there's any thoughts or items to discuss here. Yes.
Kathleen Harper for the record. I know that that's been a topic in the past, not necessarily on the agenda of board meetings, but I've been aware of it in the PEB board context before. And I very much agree with Member Duncan's comments that tug of war type, dynamics are not what. Yeah, I agree about not trying to think in those terms, and that kind of language comes up.
Yep.
I like to think outside of that.
Okay.
Yeah.
Other board members? I realize we have one board member online who I'm not seeing a hand go up or her come on screen, but making sure she also gets the opportunity.
No, I appreciate that.
Any other top discussion point or any other comments the board wants to make regarding the risk pool topics and any other discussion points?
I want to make a couple comments. And one addresses the public comment at the beginning. The separation of the retirees at risk pool would require a statutory change. That is not something the board could do on its own. It would have to propose legislation to actually put that, to divide the risk pools in place. Not impossible, but an additional step that would have to be taken. The legislature's role historically has been to provide the funding on the employer side for the plans. The board has chosen the benefits to provide with the money that's been allocated by the legislature. We continually have to think about, will we get more money in this upcoming legislative session, given the other priorities that are going to be out there looking for additional funding. I wouldn't expect a lot of new money or additional money, given some of the things that we know are coming down the pike. So given that, what kind of thing, that's kind of where we are, you know, the legislature last session, really for the first time, funded inflation at what was asked by the plan. So they gave the additional money for the inflation that we expected for the current biennium. I think we've been above what was initially projected in the session, but those the funding that was approved by the legislature included all of that additional trend. That's going to be hard to do if it keeps in the double digits. It will be hard for the state to continue to fund inflation that in this plan without sacrificing somewhere else. And a lot of times those sacrifices aren't necessarily programmatic. They are other employee-based sacrifices, cost of living adjustments, and the like. And so we're constantly, you know, kind of whether we like it or not, we're constantly in this competing for dollars with every other program that's out there. You know, K-12, higher ed, other big generator or big users of state resources. So, you know, I think at some point we, the board, is kind of expected to make some of these harder decisions about where do we allocate the limited resources that we get, and how do we provide the best benefits for our members at the lowest cost. I don't know if this is the right answer or not, but I think that at some point we're going to have to do something to bend the cost curve, because I don't think that the state can continue the double-digit inflation every year after year. That's what concerns me.
So Jim, Paul Davis here, so would you suggest that when you come to these conclusions that we have various options based on what the legislature may or may not do?
No, I think that we need to look at providing the best, putting our best foot forward to the legislature, that we've done our due diligence to try and bend some of the cost curves, and maybe some of these other three that we'll talk about in the afternoon, and provide some of the context for doing some of that. And the legislature always tries to fund to the extent that they can. But there's always competing interests. We just have to be cognizant of it.
I just always like to have fallback positions in case something goes by.
So, Andrew Sherman, in my facilitator role, we had planned to do 2 of the 5 before lunch. We'd also planned on lunch at 12:15, which is nearly 45 minutes from now. So we are at a point where we can dive in and do the next one and probably be on the same time for lunch or have lunch early? Our preference would probably be to dive in.
Yeah.
Okay. Is that work for the board?
Sounds good.
Okay, and this is, I think, us and Miller.
Millman, yes.
So
Mary
just
Ellen.
check in on Mary
there?
Ellen, she's here.
Okay,
There she
great.
is.
Okay. So there's a longer list here, lots of topics. My contracting's over here. Again, kind of a lot of votes with coordination with Nevada Health Authority and Medicaid. I keep saying votes, sorry. A lot of,
Interesting.
Yeah, little dots, interesting.
a lot of interest. Audits are of interest. We can talk about that and what that looks like. We also have docs on direct contracting, reference-based pricing, expanding COEs or centers of excellence, direct primary care as well, and point solutions. So we're going to start off, and Dr. Duncan, the first part is to talk about, is your network competitive within the state? So I think we're going to start off with that, Mary Ellen. If you're ready to go, we'll turn it to the next slide and have you walk through this.
Great. So when we, Mary Ellen Vargas, when we look at evaluating the strength of a provider network, there are a few different ways to do that. The first thing that we'll talk through briefly here is what we call a traditional network discount and disruption analysis. What this is trying to assess is the relative strength of the provider reimbursement rates, the network discounts available through different network partners, different carriers, different third-party administrators, as well as disruption. So if you're not familiar with that term, disruption implies effectively the breadth of the provider network, right? So how many providers are in the network, and of the providers that PEB members utilize today or have utilized historically, how many of those are in different networks available through different carrier TPA partners? So that was the focus of this first analysis. A few important notes here, some caveats and some limitations to this analysis. So first being that we did not conduct a full procurement initiative, obviously, right? That's a significant undertaking. There needs to be approval in place to do that. So this was positioned as more of a request for information. And we use a standardized database, it's called UDS, of discount data that national carriers submit to be used for these analyses. One of the stipulations of being able to use that data and present it in a public forum like this one is that the results need to be on a blinded basis. So we know behind the scenes, and obviously if PEB elected in the future to go through a full procurement initiative, you would have visibility into which carriers, which networks are, offering different levels of discounts and disruption. For this exercise, we're really just comparing relativities. So you'll notice that we label each carrier, A, B, C, D, and we can see where there are differences or maybe alignment. And what that tells us directionally is whether there are multiple potential viable partners, or if the scope of viable partners is maybe more limited. The other thing that I'll point out that I think is important to note here to kind of set the stage, there is one national carrier that declined to participate in this RFI, request for information process that we conducted. They cited concerns over, despite our reassurances that these results would be blinded, they were hesitant to disclose what they consider proprietary network pricing information. I'll talk more a little bit about that when we talk about kind of the second perspective from which we view network competitiveness, but I think we can jump to the next slide unless there are any questions on sort of the process here. Okay. So high-level results from a discount perspective. And again, these don't show us the actual discounts, but they show us the relativity in average discounts between carriers. So we approached 4 national carriers that have a presence in, the vast majority of states, but all have a presence in Nevada. And like I mentioned, 3 of the 4 agreed to be included in this analysis. We just set the carrier with the lowest average discount gets a 100% relativity, and then the other carriers we compare from there. So you can see carriers A and B are pretty similar in terms of their network pricing and their discount strength. So the lowest, like I said, we set at 100%, and then the next closest, which is carrier B, is at about 102%. Carrier C on an overall basis is at about 112%. What does that tell us? That, if PEB were to decide to conduct a procurement exercise, not to say you would necessarily exclude any of these carriers, but this would give you a preview that of these 3, likely only A and B would be able to propose a competitive offer from a network discount perspective. A 12% differential is pretty meaningful. And for context, anyone who's not familiar, when we talk about discounts, that's really the difference between a billed charge, kind of the list price for a medical service, and what we call the allowed charge, which is what the plan is responsible for after the claim has been adjudicated and adjusted for any discounts with your TPA or your carrier. Because claims are the biggest component of your program cost, right? That's what we focus on when we are evaluating these networks rather than something like administrative fees. So again, a 10 to 12% difference on discounts translates to a really meaningful dollar amount when we look at total claims. So again, wouldn't necessarily say carrier C would be excluded from a procurement process, but this is indicative that there are, of these 3, 2 are more competitive. And then on the next slide, this looks at what I referred to earlier, the disruption. So here we looked at historical actual PEB utilization, and I should clarify as well that we focused here on the non-HMO plans. So we have an analysis, and we could share as a follow-up if there's interest in that information on the Health Plan Nevada utilization run through these broad national networks. But to be on more of an apples to apples comparison basis, we focused on the plans that are administered by UMR today when comparing to these broad national PPO networks. So of the providers that PEB members are already utilizing, about 96% of them are in network with carrier A, and just under 98% of them in network with carrier B, and a slightly lower percentage at around 95% in network with carrier C. So the network penetration is strong for all 3 of these carriers. This indicates, when we think about this in conjunction with the discount information, carriers A and B, when you combine their network penetration with their average discounts, collectively, potentially could offer a competitive proposal if PEB went to procurement for plan administration. So this doesn't necessarily say a procurement should be conducted. It doesn't necessarily say what the outcome would be. Again, there are vendors that didn't participate in this analysis. But at a high level, this just tells us it may be something to consider going forward and exploring if this hasn't been assessed in several years. It's also important to note that provider networks are kind of living, breathing things. They're always changing, evolving. Renegotiated contracts are, a regular occurrence, especially every few years. So these things can change even if, very similar analyses have been done historically. We do sometimes see things shift over, 3 to 5+ year time horizons.
Okay. These topics are a little bit heavy, and so I'm going to continue on unless somebody stops me. My brain's rambling right now. Thank you. Just say next. Okay. So one of the things that we've done is we looked at repricing claims, taking all the claims of PEB during a 12-month period, historical 12-month period, and we repriced them to say what are those claims as representative as a percentage of Medicare. I shouldn't say many, there are a number of state entities that either has had legislation recently or has looked into, and this a lot of time is called reference-based pricing. So this is what we're calling reference-based pricing. A number of states have had legislation. My own state, Colorado, had legislation last year, and they tried to pass reference-based pricing. One of my other clients had it, and they did get it passed. It is implemented in their plan in their state. And so the question is, there is meaningful savings that we have found in incorporating reference-based pricing. There's pros and cons to that. The hospitals don't like it, obviously, because you're cutting the reimbursement rates. And so what we're showing here, and what I've typically seen in a number of states, is really focusing on inpatient and outpatient. So one of the things that has shifted in dynamics in healthcare is if you think about, gosh, you're going to the hospital, that's the expenses. And it is, because maybe the intensity of care. But when we look at the cost as a percentage of Medicare, they're lower on average than what we're seeing on the outpatient side, particularly the shift of services like surgeries from inpatient to outpatient. That used to be a savings to the plan. It's no longer the case these days. And so we're seeing costs similar to what they used to be on inpatient now on the outpatient side for surgeries. And percentage of Medicare, you're seeing it. So for your membership, we're seeing, inpatient represents 16% of allowed costs. The percentage of Medicare is 164%. Outpatient is about 40%. This includes ER, other outpatient services. This includes medications provided more intravenously on the medical side, number of other services. That's 40% of your allowed costs. Percentage of Medicare is 262. If you combine inpatient and outpatient, it's 223% of Medicare. Now, there is potential savings, limiting the amount of reimbursements provided from hospitals, but it comes with a battle. I'll just share. It's never an easy thing to do. I haven't seen, and I don't know if you guys have seen, and Mary Ellen, please step in. I yet have seen kind of professional services incorporated into reference-based pricing. Have you seen that, Mary Ellen, in your experience with other states?
Not broadly. Yeah, I would agree.
Yeah. So typically I've seen the focus again on inpatient and outpatient. And this is looking a little bit more. We've broken out the costs from Northern versus Southern Nevada and then out of state. So the story here is that this is the combined inpatient outpatient facility. Northern Nevada is more expensive than Southern Nevada. So depending on where you set, potentially, if you're going to set the threshold at 200%, let's just say for giggles, Southern Nevada is pretty close right now. Probably not much savings in Southern Nevada. Your savings are going to be coming from Northern Nevada hospitals. Just sharing that. And then again, we're showing the dollar distributions. Again, outpatient from a distribution has the higher dollars associated than inpatient. And then we're showing the differential in outpatient facility. Dr. Duncan, here's your outpatient facility out of state, 331% of Medicare. 2.6% of members are out of state. The question is, how many retirees are out of state? Yes, and probably most of them, right? That 6% is probably mostly retirees, yeah.
Wait, Harper, for the record, clarifying question, number of claims, there are triple the claims in Northern Nevada compared to Southern Nevada, is that accurate?
Yes.
Okay. Want to make sure I'm reading that right.
Is that because, Keiko, second, is that because of population spread though? Or is that really like the same population spread and just how it's different?
The members who are utilizing services in Northern Nevada. So this is just the number of claims based up.
Does the percentage column match the number of claims column?
Oh, this? No, this is dollars. Oh,
Here.
no, allowed costs. This
Yeah.
is a percentage allowed
That's
cost.
what I wanted to.
So, sorry.
I think what, Laura Rich, for the record, I think what Keiko's asking is, do we have a larger population in the north versus the south? And I don't think that's the case.
That's not the case.
You know that, yeah, I
They're
think,
just generating more claims.
okay, so, is that what you're asking? Okay.
Which is a really interesting point, right? That's a really, there's other potential things to explore there.
Okay.
Yeah, that's what I was trying to get at. I think like to have that big of a spread, I like that tells me, I
How is
think
care
if they
being
were-
managed?
Yeah, network care management, utilization. I think there's a lot of other things here. Yeah.
There's a lot more to unpack there for sure. Yep. Agreed.
Let's, if you don't mind, I'm curious, Paul Davis, what's your analysis for this huge differential on the amount of claims between the north and the south?
I haven't looked at, we did look at risk scores at one point, and I don't remember offhand, but depends on the risk scores of the members. Like, do they have more conditions in the north versus south? And I don't remember that offhand, but we can get to that information. But there's potentially, to what Dr. Duncan, there's probably a number of influences which is generating this, not just one isolated influence. Could be risk score, could be how care is being offered, kind of quality of care, could be, procedures that the doctors are ordering. There could be a number of circumstances that providers or,
And just to clarify then, Keiko, for the record, this is member area, so this is, so. Let me think about this, so you don't have to translate for me.
I'm so sorry.
No, it's okay. So if the member lives in Northern Nevada, and say they received care in Southern Nevada because there was specialists that they needed to go to, is that reflecting here as a Northern Nevada percentage because that member area is Northern Nevada?
It's by member area. Yeah. So if they went to see service,
Went to see the service in Southern
they're going to be
Nevada,
considered
they
north.
Reported as a North.
Yes, that's correct. That's correct. The issue for that is because based upon how claims are coming in, we get codes of providers, but sometimes the tax IDs or the provider codes aren't specific to that given northern versus southern region, if that makes sense. And so we went by member versus by the provider tax ID because of how the information is given to us can be misleading. Yes.
You're talking about member area, true expression for the record. Are you like splitting the state in half? Like, how did the rurals get counted in that? Like,
Yes.
percentage of the rurals in the north? Because I think to Dr. Duncan's point, that'll probably help. That's probably part of
We
that.
had a map, and I don't know if we can pull it up, but yeah, it's based upon, we've done some analysis for you before. We've split up north.
Is it fair to say, right, because a lot of
More
the
rural.
rural members are going to be directed south or out of, like all over the state really. And so if their rural area was considered in that northern Nevada hemisphere, then that might be part of the
66%.
It could be, yes, because again, it's based upon where the member lives, but if they're using services in the south, they're gonna be, this number of claims is gonna be considered north because that's where the member lives. If they're using services in the south, the member resides in the north. The claim and all the data we're showing is based upon north versus south here.
So I think, Kate, for the record, I wonder where that table is relevant then, because I mean, that tells me not really like even a network problem. I guess I think there's a lot of other things that could possibly be the barrier to affecting that. I think I'm a little bit, I think the cost differences and, the percent of Medicare and like, the way the dollars are distributed, I think maybe that like tells a little bit more of the story specifically. But as a complete aside to this specific conversation, because I think that's maybe a little bit out of what this conversation is, okay, which I'm, great at doing. But I think it poses some questions about, service adequacy. So not even like network, where is the care happening and how is that management being coordinated and things like that maybe might be of concern for this conversation over here. Okay, yeah.
Yep. I think the big takeaway too is just looking at the percentages, right, of Medicare and the reimbursements there. Okay. We did see in the north that there were 3 hospitals with combined facility reimbursements of 400% and over. Obviously, Southern, this is nothing new. Southern Nevada had the lowest reimbursements as a percentage. And we've seen in general in doing this analysis, in the more rural settings, the percentage of Medicare is much higher. In comparing urban versus rural, I've seen in a number of states, including yours, much higher percentages in reimbursements, facility, hospital reimbursements in the rural areas compared to the urban. We did see the impact of Carum Health, which is a point solution, which is something we're going to talk about later. We did see some positive effects from a pricing standpoint for those facilities, which were engaged with Carum Health. So saw some meaningful reductions in percentage of Medicare compared to similar facilities that were not engaged with Carum. This is breaking things out in more detail, inpatient by services, and then outpatient, and what's generating kind of that 262%. So as you can see, ER, no surprise to everybody, that's one of the more expensive sites of service to get care. Percentage of Medicare is just shy of 500%. Again, helping members, and we can talk about this, making sure they're going to the ER for the right reasons. We did some analysis on that. It looked overall that there are members that are going to the ER for more of those higher level conditions. There's potentially some noise of avoidable ER utilization, but we're also seeing those, I'll just remind everybody, there are freestanding ERs in Southern Nevada, and they're typically backed by private equity. And we have seen it systemically in a number of states where they tend to push to the higher coding of condition to, the level 4s and 5s, and they tend to have higher costs than other ER facilities. Another thing that's breaking out, but again, we have to look at the percentages as well. Dialysis, it's only 1% of total allowed, but the percentage of Medicare is really high. So something to think about is, do you direct contract? If you're going on to dialysis, are there certain facilities that you could direct contract with to make a deal to drive your members to certain facilities? The other area is again, PT, OT, that's physical therapy, occupational therapy. Hopefully I got that down. 516% of Medicare. There's a lot of point solutions out there where you can do some of those things from the comfort of your home with direction of a provider and a therapist kind of online that can really help save money. And that's going to get in our conversation this afternoon about point solutions, but we've seen some good savings in other plans when we've looked at and done an analysis and they've had high outcomes. That's something to think about. I should say high member satisfaction outcomes. I'll say we've seen positive outcomes from members who utilize those services. You already have Karen right now, so we'll talk about that later, about potentially expanding that. This again is professional and ancillary. I think we can move on to the next slide. I think I covered most of this. You know, again, outpatient is higher than inpatient. Yes.
Back one slide.
Yes.
Saw something.
Yes.
Something just is interesting to me. The 92% for mental health, is that, and I'm just saying that because we have such a, you know, I've heard it over and over. We've got a shortage. We have a shortage yet. We have a shortage of professionals in that mental health category, and access to care is so hard, yet we're paying them less than what Medicare is paying. So, I mean, can you speak a little bit to that?
Yeah, I mean, it's 8% of allowed, and I don't know if you have contracts specifically, or there's some kind of contracting that UMR has. It's definitely something to investigate. But I hear you, and I don't know as well that we could look into. I don't think there's online services as well, and I don't know if that flows through UMR claims. I think we need to look into that because those tend to get reimbursed at a lower, or sometimes, and so. But you're right, that is lower. So we'll
I'm not advocating to pay more for services, but and mental health is, you know, obviously such a problem, and we have such a demand for mental health services. So that just is surprising to me.
Do you have any comments or anything you want to add?
We were asking if the doctor on demand claims were part of that. That's what. Because that goes to your online.
I know. I don't know.
And then the other
I need
thing
to look into that
is
piece.
because right now PEB doesn't have access to pricing information for contracts that UMR holds. So, I mean, we could definitely ask about that, but we're not currently aware of the status of those.
Yeah. Worth a little bit of investigation, exploration. Thank you. Okay, how are we doing?
You're at 26 minutes of an intended 30 on presentation 3. So I think we're
Pretty good then.
pretty good.
Okay.
So certainly 5 minutes fits the schedule.
Did you want to address this slide, or do you want me to talk about this? Is coordination with the health authority?
Oh, yeah, I mean, we've kind of, in the last year, kind of talked a little bit about this. So the health authority was established and PEB was placed under the health authority to kind of take some of that leverage in coordinating care and contracts to increase the number of lives and spread the costs and hopefully get better deals for certain contracting. So I think in the next year or so, we'll be coming to the board and asking for either delegation authority to have NBHA and PEB related combined RFP similar to like our pharmacy benefit manager possibility solutions. And then again, I think the director has shared with the board that she's having Milliman do some analysis stuff, and once she has those results, she would bring that information back to the board and talk to you about any future RFP coordination that might cross over. And so some of the things that we've talked about are standardizing, networks, possibly combining keep, pharmacy benefit manager, scope of works, and then various things that are listed here, related to the possibility of direct, contracting. So when we talk about direct contracting later, that's not something that our PEB office is set up to run, but it might be something that the Nevada Health Authority can expand into because they already have some of those infrastructure built up through Medicaid. And so that's always a possibility of piggybacking off of that as well. Like capture all of
I
that?
think you did. And I think on the next slide, just give some things as consideration with the coordination that they're going to be looking at some of these things over time, but more to come. These are a couple areas just to think about for, as the health authority is thinking about, ways to save money. But those are probably a couple years out, I would think.
Yeah.
Okay. So there's a bunch of other things on this program, on this list, that we can definitely talk about. We talked about point solution vendors. I mentioned a couple, Karen. There's a lot of other point solutions that we could think about, maybe helping some PT, OT kind of support, and then audits. And so, not to put you on the spot again, but we had a lot of discussion yesterday about audits. So PEB does do audits, but do you want to talk about maybe some other kind of audits that you guys have been talking about internally and thinking of exploring?
Yeah, so I think currently PEP has a contract with Claims Technology. Sorry, are you laughing at me? I like to hide myself. Claims Technology Solutions, CTI, to perform audits on our PBM, ESI, and UMR services for claims reviews. Now, when you guys read those reports, you'll see that there's a small subset of claims that are being audited on a quarterly basis. So it's by no means, going to capture fraud, waste, and abuse of every claim. There are some other states that have audit entities in place that look at that from every claim level kind of solution. And I think Member Rich could speak to at the Teachers Health Trust, they have a product called Smart Light, and that's using kind of like an AI engine to kind of review claims as they come into the system, and then trying to go back and recapture money that they think was inappropriately paid to providers. So similar to that product, PEB and the health authority are looking to work with a vendor that we already have under contract doing similar work with Medicaid to see what it might cost. There's always a cost, right? But right now they're willing to do it under a contingency basis, which basically means that for a percentage of funding that they can recapture through claims assessment, then they would do the work for a percentage of whatever they recover. So it wouldn't be exactly us trying to find money to generate that audit vendor, right? And so we have to be really careful, right? Like I heard Debbie say to me yesterday, are you interested in getting another vendor? Anytime you get another vendor or increase vendor services, it's always going to cost more money. So we got to be careful about that. So this solution that we're going to try to implement in the next year will be helpful because they've agreed to do that on a contingency basis where other vendors needed to be paid up front. So we just don't have the authority to go contract that different time. But I think Member Wells was speaking to me yesterday about some auditing services that have had back under his era of where they were more intense, I believe, and more coordinated and ran through. So I think as you guys talk about, contracting, if we need to strengthen the services that we already have, then we just need to identify in what ways we want those strengthened so that PEB staff can get cost proposals to see what that change might increase in our costs. and what what savings might offset there. So we'll have to do some sort of analysis if you guys come back with needing additional, audit services.
Mary Ellen, any additional, thank you. Mary Ellen, any additional comments that you would like to make on these topics?
I would just quickly add on the topic of direct contracting with specific hospitals and providers. I kind of alluded to this when I talked about our traditional network analysis, that there's another lens from which we look at network strength. I won't get into all the details, but if you're familiar with some legislation that passed at the federal level within the last 5 or so years, plan administrators, so carriers, TPAs, health plans, payers, we kind of group them in as payers, as well as hospitals, are now required by federal law to submit what's kind of collectively known as price transparency data. That data is publicly available. There are many challenges that come with interpreting that data, but that's one of the analyses that we're conducting on behalf of the health authority. So just thought it might be useful to share. We have only really preliminary kind of higher level findings at this stage. We're still exploring further, but there is indication. So again, this is distinct from the traditional network analysis that we did where results are blinded. With the price transparency data, it's all publicly available information. So we can see who each of the carriers, networks, payers are. We can see all the hospitals and all of their published rates. We have a process for sort of normalizing all of that to get it on a standardized percent of Medicare basis, similar to the analysis that Siegel presented. And we are finding that broadly, the United Health Group, as I'm sure will come, as no surprise, does have strong provider contracts in Nevada. However, there are select hospitals, providers, health systems where other carriers, other networks might be more competitive, for example, on the inpatient side compared to UMR, or there might be more competitive outpatient rates available. There are certain hospitals where we find, even outside of the southern part of the state, that the Sierra Care Options Network is more competitive than the broad Choice Plus UMR PPO network. So some nuances that we're exploring further, but we do think there could potentially be a case for evaluating some of these direct contracts. I just wanted to quickly provide that context, that it is something that we're evaluating in more detail.
So I think we're right on track to have 15 minutes now for a board member comment and discussion. And then Sasha's been here a long time and you all are looking at them and I haven't. So that's aim for 12:30 to take a break. Okay, so coming over here, Mary Ellen, stay close by. This is your initial dot placement. And I think a lot of that has been reflected in the discussion. So a lot around audits, a lot around health authority and coordination. And I want to come back over here. That's where we were the least specific in our savings and time horizon analysis, because it's, I think, a lot of unknowns on what that will actually, but we think that has the potential to be significant. You all in the first pass kind of did too. Interestingly, on your first pass, and then I'll be quiet and let you all talk, there weren't a lot of dots around direct contracting or seeking a new claims administrator. Okay. Board members.
I'll start, Laura Rich, for the record. I'm looking at the potential savings, and so the things that catch my eye obviously are the ones with the more dollar signs. Can you guys maybe provide some more information about the CMS
piece. That's something that I don't think I've ever considered or, been aware of, and maybe the board would benefit from hearing what that looks like.
Are you talking about the AHEAD model?
Yeah, it says, the, coordination with CMS programs or something like that, something along those lines.
Yeah, so I think there's some things that we, again, have mentioned to PEB and to Health Authority, but some of this stuff is being looked at today already with the combination of Milliman and Health Authority. But the AHEAD program, it's looking at kind of aligning, and we've talked about this, right? Aligning the Medicaid and commercial payers with Medicare to kind of help reduce that fragmentation, but also kind of being able to negotiate more globally on that. And I think that's something that y'all consider, that they're considering. And it's really kind of using the strength of both programs in order to provide, contracting broadly with both. I think there's some waivers, and I believe Nevada applied for this waiver, section 132. It's really approval to waive some certain ACA requirements. And so I think that was implemented January of 2026, and that's already being implemented. And so, that piece has already been done. And then there's the section 115 that the HSA secretary can approve kind of pilot programs that assist in promoting objectives of the Medicaid program that could potentially help kind of the overall program as well.
Do you know of any other states that have like a health authority type setup, like Washington or New Mexico, that have leveraged any of these? I know the New Mexico health authority is fairly new too, but Washington has been in place for a while.
And Mary Ellen, I don't know if you can speak to Washington. I can speak to, I'm the actuary for a number of the New Mexico plans. I'm not aware of them doing this, not to say they're not doing that on the Medicaid side. Kind of a different kind of situation.
They're not leveraging Medicaid in their public employee plan.
They're not doing that today, no.
Okay.
No, they have not done that. They've kept it separate, very separate. And to this point, they procure separately for their contracts. Everything is separate up to this point. But Mary Ellen, anything to add?
Just that for Washington, my understanding is that relatively new, within the last year or two, they are starting to leverage some of this cross-program efficiencies that, we've kind of thrown around for Nevada. Specifically, I'm aware of some between Medicaid and the commercial market, which the state employee plan also leverages. I'm not sure explicitly if it's through a 1332 waiver, but they did implement and are, assessing the impact of some pilot programs that try to get at some of this coordination across programs.
Maryland has been in place for a while, and we're the actuary as well, or
I was just watching the clock.
Okay, so just real quick for Maryland, they do some things, but they set things differently. So their like reimbursement rates are higher, but they leverage kind of similar contracting, but their reimbursement rates are different and set differently.
So I think we want to come back to this.
Yeah.
But I'm going to come back to the chart and observe something else, unless other board members wanted to comment on this at this point. So in these couple of minutes here, I wanted to draw out that there aren't any dots for near site clinics.
I can speak to that and why my dot wasn't there.
Yeah, well, I wanted to, I realized that we didn't even touch on it. I didn't want to miss it at this point in the
Laura Rich for the record, Pep actually went down this road. I can't remember, like 18, 19, something like that. It's difficult because we have state employees everywhere. And so you put a near site clinic, you got to figure out where is that near site clinic going to go and who do you serve? And in Las Vegas, you probably have to have 20 near site clinics because nothing's going to be convenient. So that was one of the problems. The other problem was that the primary care was not necessarily our problem. It was more specialty. And so what were we trying to solve for?
Okay, wanted to bring that out. Any other comments? Okay, Centers of Excellence got a dot, direct primary care got a couple of dots. Reference-based pricing got a couple of dots. All things, but again here, most of these aren't big dollars and a little more time to implement. Just to give it a little more grounding. The ones that have more dollars are the ones we talked about that were talked about in coordination with the health authority or around direct reference-based pricing or contracting with specific providers. Again, that's things just to, as we go forward. Oh, I'm sorry. Member Mark.
What sets the timeline regarding reference-based pricing at greater than 2 years?
Thank you, Blaine. I'm Debbie Donaldson. From my perspective, and it depends on each state. So I'll lean on maybe Jim for insights, but many times this needs to be legislatively approved and going through legislative session in order to get it passed. I don't know the rules specifically. New Mexico, they were able to get it passed without legislative. It came from the governor's office. So it just depends. I'm not sure what the protocol here is. So we said 2 years because sometimes it does take a couple of years once it goes through legislation and then negotiation, making sure the hospitals, updating systems and all that good stuff. It just takes a little bit more time. So it could be shorter.
Trustee Grimmer, I wanted to give you the floor if you wanted it.
I'm good, thank you.
Other board members. This is some good initial direction. I think when we come back and do the second round of dots, we can get your sense a little more. And I think there's going to be plenty more time for discussion. But we're even a little ahead of where we thought for 12:30.
Right.
Thank you, Chair Wells.
With that, we'll take a break. Let's restart at 1 o'clock.
You started at what?
1.
1.
Is that okay? Sure.